All right, let's go over the quiz for Pulmonary 1. First question, to which lymph nodes would cancer in each of the following areas most commonly metastasize? So stomach cancer goes to the celiac nodes. Cancer in the duodenum and the jejunum goes to the superior mesenteric nodes. Sigmoid colon goes to the inferior mesenteric nodes. And the scrotum drains to the superficial inguinal nodes. Next, what's the classic triad of symptoms in multiple sclerosis? So the classic triad is Charcot's triad of scanning speech, intention tremor, and nystagmus. But also remember the other common presentations, including bowel and bladder incontinence, internuclear ophthalmoplegia, and optic neuritis. And the last question, which lysosomal storage disease matches each of the following statements? So characterized by the accumulation of GM2 ganglioside is Tay-Sachs disease, and associated with renal failure is Fabry disease. All right, let's get started with the lecture.
Hello everyone, welcome to our Step 1 video on lung anatomy and physiology. Okay guys, I know I've been talking a lot of smack with this intro beef with Dr. McGinnis, but now's my chance to let you know what's really happening around here at DIT. Everybody thinks Dr. McGinnis is a mild-mannered dork who knits cat sweaters. Wrong! Well, the cat sweater thing might be right. But in fact, he's more like your Silence of the Lambs type of guy. You think I'm in a super fancy studio right now, sipping on mochachinos and having my makeup done by supermodels? Well, that's a trick question because I don't need makeup. But no, I'm in McGinnis's basement. I've been down here for years making lecture videos for him. If I don't say high yield 3 times a lecture, I get the hose. Okay, so hit that comment button and type free Dr. Lewis and McGinnis knits cat sweaters. Uh-oh, here he comes. And now for a very high yield lecture on respiratory anatomy. All right, so let's get going. First, we're going to talk about tracheoesophageal fistulas. So what is this? Well, this is an abnormal connection between the esophagus and the trachea. Now, the most common type is an esophageal atresia. This happens about 85% of the time where the esophagus ends in a blind pouch. The lower esophagus connects to the trachea. Now, because of that connection, you would probably expect to get air in the stomach, right? So on an x-ray, you would expect to see air or maybe just a bubble located in the stomach. But that's not the only type of fistula. There's actually several types of TE fistulas, and they are named A through E. And in these images that you're going to see here, the dark red is the esophagus and the purple is the trachea. So let's go through these. A is an esophageal atresia without any fistula. So as you can see, the esophagus just doesn't connect in the middle. There's esophagus that ends in a blind pouch, and then there's more esophagus down below, but it's only connecting to the stomach and nothing else. And also, there are no abnormal connections between the esophagus and the trachea themselves. B is where the upper part of the esophagus actually is going to connect to the trachea. C is where the lower esophagus is going to connect to the trachea. So this is, again, the most common type of esophageal atresia that we talked about before. We see this in about 85% of cases. Now, I would definitely know this one. Remember to look for that stomach bubble as well. D is where both the upper and the lower parts of the esophagus are going to abnormally connect to the trachea. E is where there is a fistula, but no esophageal atresia. Now, sometimes the E type is referred to as an H type. I know it's confusing, but it makes sense because the connection between the esophagus and the trachea kind of looks like an H. You should probably, again, be familiar with the different types of TE fistulas, but at least remember the type that occurs 85% of the time. That's that type C, also known as just esophageal atresia with distal tracheoesophageal fistula, where the upper esophagus, again, ends in that blind pouch. You're much more likely to get a test question on that one. All right, so I just have a couple more things to talk about the trachea before we move on to the diaphragm. The trachea is lined with ciliated columnar epithelium. Now, one potential question you may get regarding this is what happens to this epithelium when you smoke or are a chronic smoker? Well, you get what's called metaplasia. Now, the columnar cells will transform into squamous epithelium. Where else do we see metaplasia? Remember, we see this in the distal esophagus when there is chronic reflux or GERD. So we call that Barrett esophagus. In that case, we saw the opposite change. In Barrett esophagus, we saw that change from squamous epithelium to columnar epithelium with goblet cells. So try not to get that confused. In the trachea, what we're talking about here, we see metaplasia going from ciliated columnar cells, so a lot of cilia, to squamous epithelium. And why would this be significant? Well, without those nice little cilia, you can't move mucus around as effectively. Therefore, smokers, again, can't mobilize their sputum, and they can end up with a chronic bronchitis where they're constantly trying to cough up a bunch of sputum. Also related to this topic of cilia is Cartaginer syndrome, also referred to as primary ciliary dyskinesia. So this is where a patient has non-functional cilia. So this includes the ciliated cells in the respiratory tract, the sinuses, the eustachian tubes, and the fallopian tubes, and even the flagella of sperm. Therefore, these patients will have chronic infections due to poor mucus clearance, kind of like we had with smokers. They will have infertility, and some will experience hearing loss even. Now, the reason the cilia are impaired is because of dynein. So dynein is non-functional in these patients. So in Cartaginer, there is a dynein arm defect, and dynein is responsible for walking along microtubules. So if they can't do that, the cilia can't bend and move as effectively. The other strange things about Cartaginer syndrome is about 50% of patients with Cartaginers will also have situs inversus. Remember that? Situs inversus is a kind of a complete reversal of the position of the circulatory system. All right, so now let's move on to the diaphragm. So the diaphragm is a sheet of muscle that divides the thoracic cavity from the abdominal cavity. Most importantly, it allows us to breathe. Now, the diaphragm is formed from a number of composite parts in the embryo. So the most important is going to be the septum transversum. Now, understanding that kind of history of formation of the diaphragm explains why the heart, the lungs, the liver, the gut, the neck, the fascia all resonate very strongly with the diaphragm. Now, the septum transversum is a thick mass of cranial mesenchyme that gives rise to parts of the thoracic diaphragm and the anterior mesentery of the foregut in the adult. Now, after its descent, the septum transversum merges with several other structures. So these include the growing pleuroperitoneal membranes, the dorsal mesentery of the esophagus, and then again, the growing muscles of the abdominal wall. So it acts as sort of the meeting place for the embryological development of all these cavities. So what if you have a problem with the diaphragm? Well, you might get a hernia. A diaphragmatic hernia occurs when abdominal structures enter the thorax. Now, this might occur in infants as a result of a defective development of the pleuroperitoneal membrane. Remember, that was one of the components. Now, a congenital diaphragmatic hernia can have some serious complications. Now that we have abdominal contents in the pleural cavity, there is compression of the lungs, and that can lead to lung hypoplasia. So these hernias occur most often on the left side, and there's also an association with polyhydramnios. Now, severe hernias can present at birth in a patient with a flattened abdomen, cyanosis, inability to breathe normally, so be on the lookout for that. However, a more common type of hernia is the hiatal hernia, where the stomach herniates upward through the esophageal hiatus of the diaphragm. Now, a sliding hiatal hernia is the most common. The GE junction can be displaced and is often referred to as an hourglass stomach. Now, there's also the paraesophageal hernia, where the fundus moves into the thorax, but the GE junction is still normal. It's in its normal location. Again, sliding hernias where the GE junction and the cardia of the stomach protrude through the esophageal hiatus. And then again, the paraesophageal hernia, only the fundus herniates through the esophageal hiatus. What else about the diaphragm? Well, the diaphragm is innervated by the phrenic nerve. It's C3, C4, C5. That famous mnemonic C3, 4, 5 keeps the diaphragm alive. Now, one important clinical note is that the growing diaphragm drags the phrenic nerve down from the cervical region to the thoracic region. Therefore, irritation of the diaphragm frequently presents as neck and shoulder pain. This is also how it's going to explain why patients with gallbladder disease or a ruptured spleen will often have referred pain to the shoulders. Now, the last bit about the diaphragm is what structures traverse the diaphragm and at what level. So the structures that perforate the diaphragm, at T8, you have the IVC going through there, inferior vena cava. At T10, the esophagus and the vagus nerve go through. At T12, you have the aorta, the thoracic duct, and the azygous vein going through. So one mnemonic that just as one part of this is T12, you see red, white, and blue. So red for aorta, white for thoracic duct, blue for azygous vein. Another mnemonic, kind of a longer one that I like, I ate 10 eggs at 12. So I is going to stand for your IVC, 8 is for 8, 10 is for 10. Eggs, this one's kind of the only structure. Eggs is going to stand for esophagus and for vagus. So eggs, vagus, esophagus. That's how that one goes. Cranial nerve 10 on that vagus as well. At AT is going to be for aorta and azygos, and the T is for thoracic, and then 12 is for 12. So you can kind of see how that mnemonic kind of groups all those things together. Okay, so now to cement this into your minds, I want you to stop the video, take just 30 seconds. I want you to write down the 4 embryologic structures that make up the diaphragm, and also write down what innervates the diaphragm as well. Okay, so what were those things? Remember, those four structures were the septum transversum, the pleuroperitoneal membranes, the dorsal mesentery of the esophagus, and the abdominal wall. And what innervated it? Remember, it was the phrenic nerve C345 innervating that diaphragm. So if you didn't get those, you probably need to review again. Moving on to a different subject, we're talking about some airway zones at this point. So when you look at the respiratory tract in general, we can divide the different areas into areas where gas exchange is taking place and where areas where gas exchange is not taking place. So the conducting zone will include the nose, the pharynx, the trachea, the bronchi, the bronchioles, and the terminal bronchioles. Do we have gas exchange in these areas? The answer is no. This is just the pathway to get air to the important gas exchange areas. So this will be referred to as anatomic or anatomical dead space because this is not grabbing oxygen from the air and putting it into the blood. But it does do some things. It filters the air, it warms it up, it also humidifies the air as well. The other zone is called the respiratory zone, and obviously this is where this is the area of gas exchange, and it includes the alveoli, the alveolar ducts, and the respiratory bronchioles. Now, if you have any pathology in the respiratory zone, then you may get another type of dead space. Recall that we just called the conducting zone anatomic dead space. That sounds bad, but every normal lung has that. Now, if you get pathology in the respiratory zone, then that area has impaired gas exchange and it produces another dead space. Therefore, that area of pathology plus your anatomic dead space is your physiologic dead space. And that will be important later on with pathology. Let's talk about some lung anatomy, and hopefully you didn't forget all of your lung anatomy from first year. The right lung has 3 lobes, the left has 2 lobes, and the lingula. Now, one very important fact to know is that the right lung is the more common side for an inhaled or aspirated foreign body, because the right main stem bronchus is wider and kind of more vertical than the left. So the common test question is a 2-year-old who swallows and aspirates a coin. Where is the coin going to most likely lodge? Well, the answer is going to be the right main stem bronchus. The same scenario can also happen with aspiration pneumonia. You're more likely to get it on that side. So each of the tertiary bronchi serves a specific bronchopulmonary segment. So these segments each have their own artery. Thus, each bronchopulmonary segment is supplied by a bronchus and then 2 arteries, a pulmonary artery and a bronchial artery, which run together through the center of the segment. Now realize that the veins and the lymphatics actually drain along the outside, along the edges. Now there are 10 bronchopulmonary segments in the right lung. So there's 3 in the superior lobe, 2 in the middle lobe, 5 in the inferior lobe. And then there's going to be 8 to 10 segments on the left, so 4 or 5 in the upper lobe, 4 or 5 in the lower lobe. So each segment is separated from the others by a layer of connective tissue. So this means that each bronchopulmonary segment is a discrete anatomical and functional unit. And this separation means that a bronchopulmonary segment can be surgically removed without affecting the function of the other segments, which is really great. Let's move on to pneumocytes. So pneumocytes are the cells that line the alveoli and are responsible for gas exchange and some other things. Now there are 2 types of pneumocytes. Type 1 pneumocytes are simple squamous epithelial cells, and they comprise well over 97% of the alveolar surface, so the vast majority. On light microscopy, they look like kind of flat, simple cells. They make up the walls of the alveoli. They're very thin. They are critical to gas exchange. Type 1 pneumocytes are unable to replicate, which is very important, and they are very susceptible to toxic insults. Now, type 2 pneumocytes are larger and cuboidal in shape. They are more typically found at the alveolar septal junction, and they only cover about 3% of the alveolar surface. Now, their primary purpose is to secrete pulmonary surfactant, also referred to as dipalmitoyl phosphatidylcholine. Now, surfactant acts to decrease alveolar surface tension, so this allows the lungs to be more compliant and to prevent atelectasis. Now, type pneumocytes are also important during lung damage. Recall how the type 1 cells don't replicate, and they're also very fragile. Now, with lung damage, the type 2 cells can replicate and can then replace type 1 cells, or even sometimes they can differentiate into type 1 cells themselves. Now, you should also be aware of the lecithin to sphingomyelin ratio. So this comes into play when we have premature labor or some other complication during pregnancy, which would result in the delivery of a premature infant. So we take a sample of amniotic fluid, and the ratio is used to determine the lung maturity of the premature fetus. So a ratio of greater than 2.0 in the amniotic fluid will indicate fetal lung maturity. Now, if you have a situation where a baby needs to be delivered prematurely, maybe there's preeclampsia, gestational diabetes, other complication, you would want to know if the baby's lungs are mature already. Babies tend to have a great deal more problems if they are delivered with immature lungs. If the value is less than 2.0, then the baby's lungs are not mature because those type 2 pneumocytes aren't making enough that dipalmitoyl phosphatidylcholine yet, that's surfactant. Now, what can you give the mom to mature the baby's lungs? Well, you could give the mom corticosteroids. That's going to help to mature those type 2 pneumocytes. Now, we're going to talk about steroids and how they prevent the neonatal respiratory distress syndrome in another video. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those on your own, and then we'll go through them together. First question here, what structures traverse the diaphragm and at what vertebral level do they pass? So remember that mnemonic, I ate 10 eggs at 12. So I8 is the IVC passing through it at T8. 10 eggs at T10, you have your esophagus and your vagus nerve. At 12, so at T12, you have your aorta, your thoracic duct, and your azygous vein. Next, what histological change takes place in the trachea of a smoker? So remember, this is another type of metaplasia. More specifically, we're seeing that ciliated columnar epithelia of the trachea become squamous, so columnar to squamous. Next, what cell type proliferates during lung damage? So you're more likely going to get type 2 pneumocytes proliferating. Next, what amniotic fluid measurement is indicative of fetal lung maturity? So remember that was the lecithin to sphingomyelin ratio, and it's greater than 2.0. Next, a young woman has infertility, recurrent URIs, dextrocardia. Which of her proteins is defective? So this is Cartaginer syndrome, which is the easy part. The hard part, what's going on? They have those non-functional ciliated cells because the cilia can't move. The reason they can't move is because dynein is non-functional. So it's a dynein arm defect, and dynein is responsible for kind of walking along microtubules. If they can't do that, and that cilia can't bend and move the way they want to. All right, and we have one rapid fire fact, chronic sinusitis, infertility, situs inversus, same thing, Cartaginer syndrome. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time. It's time for another warm-up review. Let's get going. What nerve is most at risk of damage from each of the following injuries? So first we have fracture of the shaft of the humerus. That's going to be likely to injure the radial nerve. Fracture of the surgical neck of the humerus. That's going to be the axillary nerve. Supracondylar humerus fracture. That's going to be the median nerve. Next, a high school athlete falls on his arm during practice. In the ER, a radiograph shows a mid-shaft break of the humerus. Which nerve and artery have the highest risk of damage? What muscular actions would be affected? So this is going to be the radial nerve and the deep brachial artery. And then what muscular actions are we going to affect here? With this, you're likely to have a wrist drop and loss of brachial radialis reflex. Next, what is the female homologue to each of the following male structures? So the female homologue to the scrotum is the labia majora. The homologue of the prostate gland is going to be the urethral and the periurethral glands of Skene. Homologue of the glans penis is the glans clitoris. That's it for the review. Let's get to the video.
In this video, we're going to continue our discussion of pulmonary physiology, and we're going to talk about lung volumes and also the pulmonary circulation. Now, lung volumes are about a 3-star topic, but it's really just a matter of definitions. Basically, you have to know what residual volume means, and expiratory reserve volume, and tidal volume, and so on. So take a look at your study guide, and I want you to pause the video and label these lung volumes as best as you can, and then we'll go over the answers. I'm going to go through these a little bit out of order so that we can talk about what each one is. So let's start with B. B is the tidal volume. That's the amount of air that you move in and out of the lungs with each normal, relaxed breath. And A is the extra amount of air that you can bring in when you take a great big deep breath, as deep as you can. That's called the inspiratory reserve volume. That's how much reserve lung capacity you have. And if you add those two together, add the tidal volume plus the inspiratory reserve volume, that gives you E, which is the inspiratory capacity. Then C is called the expiratory reserve volume, or ERV. That's the volume of air that you can force out of your lungs beyond what you normally expire. Then D is called the residual volume. This is the amount of air left in your lungs after you exhale as much as possible, because you can't
possibly ever totally empty your lungs, right? F is the vital capacity. This is everything except the residual volume. So you breathe in as deeply as you can, and then you blow out as much as you can, and that's the vital capacity. It can also be expressed as the expiratory reserve volume plus the inspiratory capacity. G is called the functional reserve capacity. This is the amount of air left in your lungs at the end of a normal relaxed expiration. It's basically the residual volume plus the expiratory reserve volume. And then H is the total lung capacity. So make sure you know what each of these terms means and how they relate to this diagram. And one useful hint is that A through D, all the individual vertical brackets, are called volumes, while the combinations of volumes, or E through H, are called capacities. And we've included a link to a PDF of this diagram so you can practice labeling this as much as you need to.
And then just like there's some air in the lungs that you can't ever force out no matter how hard you exhale, we call that the residual volume, there's also some air in the lungs that isn't participating in gas exchange, and we call that the physiologic dead space. Now this is another 3-star topic, but we're going to need to dig a little deeper. The anatomical dead space is basically the air in the airways, the bronchi and the bronchioles, where there's no gas exchange occurring. And then the functional dead space includes the apices of the lung, which are capable of gas exchange, but no gas exchange is happening because there just isn't much blood flow up there. Without much blood flow, there isn't much gas exchange, so it's just more dead space from a functional point of view. We can't directly measure this dead space, but we can calculate it. So look at this equation. The volume of dead space equals the tidal volume times some ratio. Now what was the tidal volume? It's the air that moves into the lung with each quiet inspiration. But again, some fixed percentage of that volume of air is going into this physiologic dead space. So that's where the ratio comes in. You take your PaCO2 minus your PeCO2 and you divide that number by your PaCO2, and that gives you the percentage of the tidal volume that is dead space. So PaCO2 is the partial pressure of CO2 in the arterial blood, and PeCO2 is the partial pressure of CO2 in the expired air. Now if you had zero dead space, all the arterial CO2 would be breathed out. So PaCO2 would equal PeCO2, and this ratio would be 0. But we know there's always some dead space where no gas exchange is going on. So if the tidal volume is, say, 500 milliliters, and if 10% of that tidal volume was dead space, because you use this ratio to come up with 10%, then your physiologic dead space would be 10% of your tidal volume, so it would be 50 milliliters. So do you really need to memorize this equation? Well, it's about a 3-star topic. A lot of you won't have a question regarding this on your test, but a handful of you might. So not hugely high yield, but maybe worth learning. Now let's talk about the dynamics of the lung and the chest wall. Let's take a look at this graph. Unfortunately, this graph is anything but intuitive. This is a graph showing the relationship of the dynamics of the lung and the chest wall at different pressures. So the blue line is the chest wall, and the red line is the lungs. And as you move from left to right, going up in pressure along the x-axis, the volume on the y-axis is also increasing. And when the pressure is 0, that represents atmospheric pressure. So what does the chest wall want to do as the pressure moves from left to right, going from subatmospheric pressure to supraatmospheric pressure? Well, it wants to greatly increase volume. So let's think about that for a second. The chest wall is exerting an outward pull as airway pressure increases. The chest wall has a tendency to expand and to spring outward, but something is preventing it from doing so. So what prevents that? The lungs. The lungs want to do the opposite. As the pressure in the lungs goes from positive down towards 0, the lungs want to collapse. And unopposed, the lungs would collapse at a pressure of 0, which is what happens with the pneumothorax. You equalize the airway pressure by puncturing the chest wall, and the lungs collapse. But fortunately for us, at atmospheric pressure, our lungs don't actually collapse. Why not? Well, because the chest wall is trying to spring outwards. So the green line in the middle represents the balance between those two opposing forces. There's also a horizontal line labeled FRC. That's the functional residual capacity, which is the volume in the lungs after normal expiration. So this is the point at which you have perfect balance between the outward expansion tendencies of the chest wall and the inward collapsing tendencies of the lungs. So that pressure in the system is exactly equal to atmospheric pressure. Now, the FRC differs from person to person. And what determines the FRC for any given individual is what we call compliance. Compliance is the amount that the lung volume changes for any given change in pressure. So lungs can either be very compliant, so that volume changes a lot with minimal changes in pressure, or the lungs can be very non-compliant, so that the volume doesn't change very much, maybe even with big pressure changes. It's like blowing up one of those long, skinny balloons that doesn't want to blow up, no matter how hard you blow it. And you'd say that the compliance is low. So clinically, in patients with emphysema, this horizontal FRC line is going to be located higher up. In other words, that balanced static pressure of 0 is only going to be achieved when the lung volume is higher. In emphysema, the lungs are more compliant. They don't contribute as much. They don't do as good a job at resisting the outward pull of the chest wall. So the FRC is going to be determined more by the chest wall dynamics, which explains why with emphysema you get a barreled chest, because the chest wall is winning, it's expanding. So increased lung compliance increases the FRC. Now, what about decreased lung compliance, such as a preemie with insufficient surfactant, or a patient with pulmonary fibrosis, or a patient with pulmonary edema? Those are all conditions where the lung compliance is low. With low lung compliance, that green line is going to start moving toward the lungs, and the lungs are going to start to win rather than the chest wall. The lungs are exerting more inward collapsing pressure on the system. So decreased lung compliance will decrease the FRC. The total lung volume will be reduced. Now we're going to shift gears and talk about the pulmonary circulation. Now, one important thing about pulmonary circulation is how it responds to changes in O2 and CO2. So the pulmonary vasculature reacts to changes in oxygen and CO2 in a way that's totally opposite from the way the systemic vasculature responds. In the lungs, a decrease in alveolar oxygen is going to cause local vasoconstriction. Now that's different than any other tissue, right? Elsewhere in the body, if you have low oxygen in the tissue, you're going to dilate the vessel so you can deliver more oxygen and reverse that hypoxia. But in the lungs, we see the opposite. Low oxygen and high CO2 causes those pulmonary vessels to clamp down, which reduces perfusion of the lung so that you're shunting blood away from the parts of the lung that aren't ventilating well, and you're shunting blood toward the well-ventilated regions of the lung. So if you have COPD, your lungs are chronically encountering this low alveolar oxygen. That's going to cause some chronic pulmonary vasoconstriction. What effect does that have on the pulmonary arterial pressure? Those vessels are clamped down, and the pulmonary arterial pressure is going to rise. This is pulmonary hypertension, right? And then the consequence of that pulmonary hypertension is cor pulmonale and subsequent right ventricular failure. Cor pulmonale is when you have lung disease that causes heart failure. And now you see why it happens, because that lung disease, like COPD, is causing local vasoconstriction wherever there's poor oxygenation. We'll come back to that in a little bit. Now, one purpose of delivering blood to the lungs is so that it can pick up oxygen and carry it off to the rest of the body, right? Well, we know this isn't 100% efficient. The air that you exhale is not completely devoid of oxygen. There's only so much of that alveolar oxygen that can actually enter the circulation. And you're also delivering CO2 to the lungs to be eliminated. But again, that transfer of CO2 from the blood to the alveoli isn't 100% efficient. So what limits how much oxygen you can get into circulation, or what limits how much CO2 you can get out? Well, gas exchange can be limited by perfusion, or in other words, by how much blood you're getting to the area, or it can be limited by diffusion, how quickly the gases can diffuse in and out of the blood. Now, under normal circumstances, transfer of oxygen is limited by perfusion. So if you want to get more oxygen into the blood, you need to put more blood through the lungs. So in a normal, healthy lung, oxygen uptake is perfusion limited. So let's graph this.
Along the length of the pulmonary capillary, oxygen is basically going to equilibrate from your alveoli to your arteries very rapidly and very early. The only way to get more oxygen into circulation is to increase the blood flow through that capillary, either putting more blood in there or by having it go through more rapidly. Now, when there's pulmonary fibrosis or emphysema, that diseased lung tissue is impeding gas diffusion. So gas exchange becomes diffusion limited, which means the gas does not equilibrate by the time the blood reaches the end of the capillary. The arterial partial pressure of whatever gas you're looking at does not ever reach the alveolar partial pressure.
Under normal circumstances, the pulmonary vasculature is a low-pressure, low-resistance system. And these vessels are very compliant. The right ventricle doesn't normally have to work very hard to pump blood to the lungs. So let's talk about what determines the resistance in the pulmonary vasculature. There's an equation, delta P equals Q times R, where delta P is the change in pressure, Q is the perfusion, or the rate of flow through the vessel, and R is the resistance. And we'll see this in the cardiovascular system when we talk about systemic vascular resistance. So it's PQR, delta P equals Q times R. And the resistance, R, equals 8 times the viscosity times the length of the vessel divided by pi times the radius to the fourth. And this formula for resistance works not only for resistance of blood vessels, but it also works for the resistance of air going through the airways as well. So if airway resistance is related in part to the diameter of the airway, that explains why bronchoconstriction increases airway resistance and decreases airflow. So what kinds of things cause constriction of an airway? Well, think about anaphylaxis, bronchospasm, asthma, and parasympathetic stimulation. These are all things that decrease the radius of the airway and increase the airway resistance. Now, how would sympathetic stimulation of beta-2 receptors affect the radius of the airway? Well, it's going to increase the radius and thereby decrease resistance. Let's go back and talk a little bit more about pulmonary hypertension, which we touched on a moment ago. If the normal pulmonary artery pressure is around 10 to 15 millimeters mercury, pulmonary hypertension is defined as pulmonary artery pressure greater than or equal to 25 at rest or greater than or equal to 35 during exercise. And just like chronic systemic hypertension causes damage to the vessels, pulmonary hypertension will do very much the same thing. And you're going to get arteriosclerosis and hypertrophy of the media of the pulmonary arteries and fibrosis of the intima. And pulmonary hypertension can also result in cor pulmonale and right-sided heart failure, as we mentioned earlier. Now, pulmonary hypertension comes in two basic flavors. There's primary pulmonary hypertension and there's secondary pulmonary hypertension, just like there's primary or essential systemic hypertension and there's secondary hypertension. Primary pulmonary hypertension can also be called idiopathic pulmonary arterial hypertension. It's associated with mutations in a gene called BMPR2. That stands for bone morphogenetic protein receptor type 2. I like it so much better when they name the gene or the protein after the disease it causes, like dystrophin causes muscular dystrophy. Why didn't they just call this pulmonary hypertensinogen or something? Now, normally this BMPR2 protein does a lot of different things, including preventing proliferation of vascular smooth muscle. So if this gene is mutated and the protein is non-functional, you're going to have excessive vascular smooth muscle proliferation. Now, what did we just say would happen when you thicken the walls of a vessel and reduce the radius? Radius is in the denominator of that equation for resistance that we were just looking at. So a thick vessel with a narrowed radius results in increased resistance and increased pressure. So this causes primary pulmonary hypertension. Now the third bullet says that primary pulmonary hypertension is associated with HIV and also Kaposi sarcoma. And it's more common in women, and the average age is 36. So this tends to be a disease of young women. So if that's primary pulmonary hypertension, what about secondary pulmonary hypertension? What causes that? Well, we mentioned before how it can be caused by chronic lung disease like COPD or pulmonary fibrosis. Remember, with chronic lung disease, you're going to have the pulmonary vessels are all going to be clamped down, and that's going to lead to pulmonary hypertension. And you can get pulmonary hypertension secondary to mitral stenosis because of increased resistance and increased pressure being transmitted backwards from the left atrium to the pulmonary veins and capillaries. And finally, that pressure is transmitted to the pulmonary artery. A third cause of secondary pulmonary hypertension is recurrent thromboemboli. Fourth is autoimmune disease. And then also left to right shunts, like from a VSD. So the right side of the heart just isn't built to handle those higher left-sided pressures. And then finally, sleep apnea or high altitude, resulting in hypoxic vasoconstriction. Again, vasoconstriction is going to cause pulmonary hypertension. So know those different causes of secondary pulmonary hypertension and know what fundamentally causes primary pulmonary hypertension. Then the last thing I want to go over is how we treat pulmonary hypertension. Well, there's a drug called bosentan and a similar drug called ambrisentan. So both of these drugs end in sentan. Bosentan and ambrisentan, and they're used to treat pulmonary hypertension. They competitively antagonize the endothelin-1 receptors, and that's going to decrease pulmonary vascular resistance. So that's one option for the treatment of pulmonary hypertension, using one of these sentan drugs. Then there are also a few other options to treat pulmonary hypertension. You can use a prostaglandin analog. Remember, prostaglandins relax smooth muscle, and they dilate vessels like the pulmonary arteries. So iloprost or epoprostenol would be a couple of examples. You don't necessarily need to know those specific drugs. Just know that prostaglandins are another option. Another option would be sildenafil. Now, you know sildenafil. That's a generic name for Viagra. It's not just for erectile dysfunction anymore. It's also approved for the treatment of pulmonary hypertension. Now, it's not called Viagra for this purpose. The brand name for this indication is Revatio. It's a phosphodiesterase inhibitor, and that causes vasodilation also. And then a fourth option would be a dihydropyridine calcium channel blocker like nifedipine. So again, the four options are a sentan like bosentan or ambrisentan, a prostaglandin analog, sildenafil, or a dihydropyridine calcium channel blocker such as nifedipine.
And speaking of sildenafil and the phosphodiesterase inhibitors, you may remember that these work by prolonging the effects of nitric oxide, which is a major smooth muscle relaxer and vasodilator. So there have been several studies looking at inhaled nitric oxide for treating pulmonary hypertension to selectively dilate the pulmonary vascular bed with fewer systemic effects like hypotension. Now, inhaled nitric oxide can be used for acute treatment of severe primary pulmonary hypertension in patients that are really sick and hemodynamically compromised. But it's not recommended for long-term use because it really isn't practical to administer, and it really isn't effective for secondary pulmonary hypertension. Now it's time for the end of session quiz. So go through those questions on your own, then we'll answer them together. First question. The following lung volumes are obtained from an elderly smoker. FRC is 5 liters, IRV is 1.5 liters, inspiratory capacity is 2 liters, and vital capacity is 3.5 liters. So what's the total lung capacity? So this is the type of question you're very likely to see. What you have to know is that the total lung capacity is equal to the functional residual capacity, which was 5 liters, plus the inspiratory capacity, which was 2 liters. So you have 5 plus 2 gives you a total lung capacity of 7 liters in this example. It's pretty easy if you have all those terms memorized. Next, if a lung collapses, what happens to the intrathoracic volume? Well, when a lung collapses, the chest wall is allowed to expand unopposed by the lungs. So while the lung volume goes down to nearly 0, the intrathoracic volume actually increases greatly due to chest wall expansion. Next, what gene mutation can cause primary pulmonary hypertension? Well, that's the BMPR2 gene, or the bone morphogenetic protein receptor type 2. Next, what are some of the secondary causes of pulmonary hypertension? So we mentioned COPD, sleep apnea, frequent thromboembolism, mitral stenosis, and left to right cardiac shunts. Next, what are some of the treatment options available for pulmonary hypertension? Well, there are 4 main treatments: bosentan or ambrisentan, prostaglandin analogs, which have prost in the name, sildenafil, or nifedipine. And then for those patients with severe primary pulmonary hypertension who are hemodynamically unstable, you could consider inhaled nitric oxide. The last question, what is the mechanism of action of bosentan? So it's an antagonist at the endothelin-1 receptor, and we use it in pulmonary hypertension because it decreases pulmonary vascular resistance. That's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. The presence of which antibodies is specific for SLE, or systemic lupus erythematosus? So this is the anti-double-stranded DNA or anti-Smith antibodies. Next, what is the mechanism of type 4 hypersensitivity? Well, type 4 hypersensitivity is when you have T lymphocytes that are sensitized and they come across antigen and then release lymphokines. Now, this is your T cell mediated hypersensitivity, or also referred to as the delayed type hypersensitivity. Next, which structures arise from the paramesonephric ducts? Well, they develop into the fallopian tube, the uterus, and the upper portion of the vagina. All right, that brings us to the end of the warm-up. Let's get to that lecture.
In this video, we're going to talk about hemoglobin, which plays a vital role in oxygenation. Without hemoglobin, the lungs would be pretty useless. The lungs are designed to deliver oxygen to hemoglobin molecules so that it can be delivered to the rest of the body. Hemoglobin is made up of 4 globin protein subunits, 2 alpha globins and 2 beta globins. Each globin subunit is bound to heme, so hemoglobin has 4 heme molecules and 4 oxygen binding sites. That's important. There's a T form, or taut form, of hemoglobin, which has a low affinity for oxygen. So the T form favors tissues. It's going to give up its oxygen very readily, so oxygen is released to the tissues. The R form of hemoglobin is the relaxed form, and it has a high affinity for oxygen. You might remember R for receptive. It's more receptive to oxygen.
And hemoglobin shows what we call positive cooperativity, which means that once hemoglobin is bound to one oxygen, it's then more likely to bind to a second oxygen, and that makes it more likely to bind a third oxygen, and so on. So this accounts for the sigmoid shape, or S shape, of the oxygen dissociation curve. We'll see that shortly. So what determines whether hemoglobin is in the T form or the R form? So CO2, hydrogen ions, increased temperature, and 2,3-DPG all favor the T form over the R form. They all favor unloading of oxygen to the tissues. Now, what's 2,3-DPG? It's 2,3-diphosphoglycerate. You'll also sometimes see it called bisphosphoglycerate, or 2,3-BPG. It's the same thing. But anyway, CO2 and acidosis and increased temperature and 2,3-DPG all favor the conversion of hemoglobin from the R form to the T form so that oxygen will be unloaded to the tissues. This makes sense. As hemoglobin carries oxygen out to the peripheral tissues, like the muscle tissues, and they're working really hard, and they're using a lot of glucose and making a lot of CO2, you would want the hemoglobin to unload the oxygen at those tissues. So when hemoglobin gets near all that CO2 that's being made in the muscles and being put in the blood, that CO2 will cause the hemoglobin to convert from the R form to the T form. And since the T form has a low affinity for oxygen, the oxygen comes off of hemoglobin and it's free to diffuse out of the blood into the muscle tissue where it's needed. Likewise, muscles that are working hard are going to be making a lot of lactic acid and creating more lactic acidosis, meaning that there's going to be more hydrogen ions around. So again, that would favor the T form over the R form. Muscle action generates heat, right? So again, increased temperature favors the T form and unloading of oxygen. Now, we're talking about adult hemoglobin here, hemoglobin A. Fetal hemoglobin is made of 2 alpha globins and 2 gamma globins. And fetal hemoglobin actually has a lower affinity for 2,3-DPG than adult hemoglobin does. So as a consequence, the fetal hemoglobin has a higher affinity for oxygen. So with adult hemoglobin, 2,3-DPG is going to favor the T form and oxygen unloading. But the fetal hemoglobin has a lower affinity for 2,3-DPG, and it's going to start binding up all the oxygen that the maternal hemoglobin A is releasing. So that allows for oxygen exchange at the placenta. Now let's look at some oxygen-hemoglobin dissociation curves and talk about the relationship between the partial pressure of oxygen in the blood and the oxygen saturation of hemoglobin. The first thing you notice about this oxygen-hemoglobin dissociation curve is that it's sigmoid-shaped or S-shaped. That's because of positive cooperativity of hemoglobin, where as you start to bind oxygen to the hemoglobin, it favors even more oxygen binding. So let's look at the blue line for now. The blue line represents normal saturation. So for any given partial pressure of oxygen along the x-axis, a certain percentage of the hemoglobin molecules are going to be saturated with oxygen. So how do we measure PO2? Well, PO2 is basically measured as dissolved gas. So when oxygen goes into the blood, some of it's bound to the hemoglobin and some of it's just dissolved in the blood. Not all the oxygen in the blood is carried by hemoglobin. Some of it's just dissolved in the blood, and we can measure that. So the PO2 is the partial pressure of oxygen, and we measure that with an arterial blood gas, or an ABG. So ABG is going to measure your PO2. Then how do we measure hemoglobin saturation? We measure that with a pulse oximeter. Pulse ox is a decent estimate of hemoglobin saturation. It's not 100% accurate, but it's a pretty good estimate. If you look at a PO2 of 100, that's pretty much normal, and around 95% of the hemoglobin is saturated there. But if you go down to a PO2 of 70, the saturation starts to drop off a little bit. And then going down to a PO2 of 50, you see the curve is getting steeper and steeper. So going from a PO2 of 70 to 40, you're going to have a big drop off in your hemoglobin saturation, much bigger than you would, say, going from 100 to 70. From 100 to 70, you're decreasing the PO2 by 30 points, but the hemoglobin saturation really isn't changing that much. But when you decrease PO2 by another 30 points, going from 70 down to 40, you're going to see a much bigger change in the hemoglobin saturation. Then, going back to the factors that favor the T form over the R form, what happens when you shift this curve to the right? Let's take a look at a PO2 of 60. On the normal curve, the blue curve, a PO2 of 60 corresponds to a hemoglobin saturation of almost 90%. But look at the red curve. When you shift the curve to the right, at a PO2 of 60, the hemoglobin is going to be less saturated, only about 80 or 82%. So again, when the curve is shifted to the right, there is less hemoglobin saturation for any given PO2 than before the curve was shifted. So what kinds of things will shift that curve to the right? All those things we said favor the T form of hemoglobin over the R form. Carbon dioxide, acidosis, elevated 2,3-DPG, increased metabolic needs like exercise or activity, and high temperature. So one popular mnemonic is to say cadet face right, C-A-D-E-T, and those are all the things that shift the curve to the right, and they favor less hemoglobin saturation and oxygen unloading. Now let's talk about shifting the curve to the left. Let's look at the green curve. You can see here that at any given PO2, more hemoglobin will be saturated than on the normal curve. Look at a PO2 of 60 again. At a PO2 of 60 on the green curve, the hemoglobin saturation is up to around 93%. So what things shift the curve to the left? All the opposite things. Decreasing CO2, alkalosis, decreasing 2,3-DPG, decreasing metabolic need, and decreasing temperature.
Those will all shift the curve to the left. And we said that fetal hemoglobin has higher affinity for oxygen than adult hemoglobin. In other words, fetal hemoglobin's dissociation curve is shifted to the left. One of the reasons why fetal hemoglobin has a higher affinity for oxygen is that it has a lower affinity for 2,3-DPG. So lower affinity for 2,3-DPG means higher affinity for oxygen and shifting the curve to the left.
Next, I want to talk about a couple of toxic forms of hemoglobin, methemoglobin and carboxyhemoglobin. So these are both forms of hemoglobin that can't carry oxygen as well as regular hemoglobin, and this leads to tissue hypoxia. So methemoglobin is the oxidized form of hemoglobin. It has iron in the ferric form. Now, one student suggested that you can remember that ferric is the 3+ form of oxygen because ferric ends with the letter C, and C is the third letter of the alphabet, so ferric is 3+. Or if you take the S in ferrous and you write it as a 2, that can help you remember that ferrous is the 2+ form, and the ferrous form binds to O2 better. And that means that the 3+ ferric form, which is the methemoglobin form, and that does not bind oxygen as readily. So methemoglobin has decreased affinity for oxygen, but it has an increased affinity for cyanide, and this can be clinically useful. Giving patients nitrites like nitroglycerin will start to oxidize some of the patient's hemoglobin to methemoglobin. So if you have a patient with cyanide poisoning, you can give them nitrites to oxidize hemoglobin to methemoglobin. And since methemoglobin has a higher affinity for cyanide, it will actually go through the body and pick up the cyanide. So you're basically converting hemoglobin into a cyanide transport mechanism. You can actually get a cyanide antidote kit, which has amyl nitrite that you have the patient inhale, and also sodium nitrite that you give IV. And then, just so you've heard of it, the second step of that antidote kit is to give thiosulfate, which binds to cyanide and forms thiocyanate, which is renally excreted. There are also other drugs that you can use to directly bind cyanide as well. In the study guide, there's a question that says, what substances are known for causing methemoglobinemia? Well, methemoglobinemia is mostly caused by medications. One of the most common medications that causes this is nitrates and nitrites. So if you have a patient having an MI and you start a nitroglycerin infusion, that's more likely to elevate methemoglobin levels over time. Other drugs that can cause methemoglobinemia include anti-malarial drugs like chloroquine and primaquine, dapsone, sulfonamides, local anesthetics like lidocaine can do it, and then also metoclopramide. Now, nitrates like nitroglycerin are among the most common offenders because a lot of patients are taking nitrates. Few people are chronically on these other medications. So if you have a patient coming into the hospital with an MI, you might start a nitro drip to relieve the chest pain while they're waiting for the cardiac cath, or just start the nitro drip to control the symptoms. So it's not uncommon to have a patient on a nitro drip for several days, and that's going to increase the methemoglobin level. So what can you do in that situation? Well, methemoglobinemia can be treated with methylene blue, and then vitamin C is another important antidote. So remember, methylene blue and vitamin C. There's one other drug that can be used to gradually lower methemoglobin levels, which is the H2 blocker cimetidine. Now, this doesn't work very quickly, so you're not going to use it for acute methemoglobinemia. But if you have to start a patient on a long-term course of one of these drugs that might induce a methemoglobinemia, like dapsone, maybe an AIDS patient who's taking dapsone, or sulfonamides as prophylaxis against pneumocystis pneumonia, you might also put the patient on cimetidine with the dapsone to decrease the risk of methemoglobinemia. Then the other clinically important toxic form of hemoglobin we want to talk about is carboxyhemoglobin. So this is a form of hemoglobin that's bound to carbon monoxide instead of oxygen. So hemoglobin's affinity for carbon monoxide is about 200 to 250 times greater than its affinity for oxygen. So in the presence of carbon monoxide, all the hemoglobin will preferentially bind to that rather than binding to oxygen. This causes a decrease of oxygen binding capacity with a leftward shift in the oxygen-hemoglobin dissociation curve. It's going to decrease oxygen unloading to the tissues. So carbon monoxide will pretty much shut down delivery of oxygen to the tissues. The tricky thing and the scary thing is that you can't diagnose carboxyhemoglobin with a pulse ox. A patient could come in with carbon monoxide poisoning and tons of carboxyhemoglobin, very significant hypoxemia, but they could still have a normal pulse ox indicating hemoglobin saturation. But the hemoglobin is saturated with carbon monoxide instead of being saturated with oxygen. So that's pretty much it for oxygen and hemoglobin. It's a short lecture, but it's kind of intellectually intense. Hope your brain's not too fried. So let's stop and do the end of session quiz before you overheat. First question, which form of hemoglobin A has a high affinity for oxygen? And which one has a low affinity for oxygen? So there's the R form, or the relaxed form, which has a high affinity for oxygen, and the T form, or taut form, which has a low affinity for oxygen.
Next, what substances tend to shift the oxygen-hemoglobin dissociation curve to the right? This was carbon dioxide, acidosis, elevated 2,3-DPG, increased exercise or activity, and high temperature. All those favor oxygen unloading. And then the last one, what is the treatment for methemoglobinemia? So you give methylene blue, and then vitamin C can also help. That's it for now. I'll see you next time.
Hello there. Apparently my mind and combat skills are so amazing that headquarters asked me to make this short training video for you all. Today's question is, what is the treatment for methemoglobinemia? First, stop the offending agent if possible, which of course it is. Second, administer methylene blue, preferably in an IV injection. What? This is a dragonberry teeny. Lesson complete.
It's time for another warm-up. Let's get going. First question here, which immunodeficiency matches each of the following statements? First, we have neutrophils fail to respond to chemotactic stimuli. So this could be Job syndrome, which is the hyperimmunoglobulin E syndrome, or it could be leukocyte adhesion deficiency syndrome, but here they fail to respond for different reasons. Next, we have adenosine deaminase deficiency. So this is SCID, severe combined immunodeficiency. Failure of endodermal development. So this is seen with DeGeorge syndrome. Next, we have defective tyrosine kinase gene. So this is going to be the Bruton A gammaglobulinemia. Associated with high levels of IgE and also high levels of eosinophils. So this is going to be hyperimmunoglobulin E syndrome again. Next, which bacterial structure fits each of the following descriptions? Mediates adherence of bacteria to the surface of a cell. So that's going to be the fimbria or pili. Protects against phagocytosis. That's going to be the capsule. Space between the inner and outer cellular membranes in gram-negative bacteria. That's going to be periplasm. Forms attachment between two bacteria during transfer of DNA materials. This is going to be the sex pilus or the F pilus. Genetic material within bacteria that contains genes for antibiotic resistance. That's going to be the plasmid. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about oxygenation. We've covered the structure of hemoglobin and how that affects oxygen binding, but there's a little more to it than that. The oxygen content of the blood includes both the oxygen bound to hemoglobin plus the oxygen that's dissolved in the blood. Basically, if you add the dissolved oxygen to the oxygen binding capacity, or hemoglobin binding capacity, times the oxygen saturation, that would give you the total blood oxygen content. That's more of a conceptual thing than an equation you need to memorize. It's just not something we use clinically.
Now you can estimate O2 saturation with a pulse ox, and you can measure the dissolved oxygen with an arterial blood gas, or ABG. But you can't really measure the hemoglobin binding capacity. You have to calculate it based on the amount of hemoglobin the patient has. This isn't really something that's important to be able to do for your exam, so let's just move on and talk about how diseases like anemia and COPD affect the amount of oxygen in the blood. How does anemia affect the blood oxygen content? When you're anemic, the hemoglobin decreases, and as hemoglobin falls, oxygen content decreases. That makes perfect sense. And it doesn't much matter why you're anemic. There are three big reasons why you might be anemic. Decreased red cell synthesis, so you're not making red cells and hemoglobin for some reason, like iron deficiency or thalassemia. Increased red cell destruction, such as hemolysis of the red cells, or the third one would be loss of red cells from blood loss or hemorrhage. Now, we'll talk a lot more about that in the hematology section of the course. But regardless of the cause of anemia, when you're anemic, the total oxygen content of the blood decreases. However, the O2 saturation that you would measure on the pulse ox does not decrease. Pulse ox is just measuring the saturation of the hemoglobin that you do have. So even if you don't have much hemoglobin circulating, if it's 95% saturated, the pulse ox is still going to read 95%. And the arterial PO2 that you measure on the ABG does not change when you're anemic because, again, that's measuring oxygen dissolved in the blood, which is independent of hemoglobin. So if you have a drop in hemoglobin, you can have hypoxemia even though both the pulse ox and the ABG are normal. So that's anemia. Now, how does chronic lung disease like COPD affect blood oxygen content? Well, chronic lung disease decreases the amount of oxygen that's dissolved in the blood. Again, that's the arterial PO2. And we mentioned earlier how the lung tissue is going to shunt blood away from hypoxic lung tissue by clamping down on those pulmonary vessels. That's called a physiologic shunt, and that decreases the oxygen extraction ratio. You have less healthy tissue that's capable of extracting oxygen from the inspired air and transferring that oxygen to the blood. So lung disease reduces the oxygen extraction ratio and the blood oxygen content decreases. And then exercise or activity, you're going to see a decrease in venous PO2. Not arterial oxygen content, but venous oxygen content will be lower during exercise. It's because most tissues don't extract oxygen maximally at rest. Most tissues only extract just as much oxygen as they actually need. But with exercise, there's increased oxygen demand, and the tissue starts to suck more oxygen out of the blood, and oxygen extraction increases. Remember, we said that substances like 2,3-DPG and acidosis and increased CO2 and increased temperature will all shift that oxygen-hemoglobin dissociation curve to the right in favor unloading of oxygen. So when you exercise, you're going to generate things that favor oxygen delivery to the tissues. So if you measured the venous PO2 of tissue at rest, those tissues have extracted just a little bit of the oxygen, just enough to get by. So at rest, the venous PO2 may be relatively high. But when you exercise, you're extracting more oxygen, so the venous PO2 is going to be much lower. Next, let's talk about the alveolar gas equation. Now, don't panic. This really isn't scary. It's not the equation that shall not be named. And don't glaze over and tune out either. It's really not all that complicated. The hardest part for me was always remembering that the big A is alveolar and the little a is arterial. So here's how I remember it. What's bigger, your lungs or your arteries? Your lungs. So the big A is for your alveoli and lungs, and the little a is for those little bitty arteries.
The alveolar gas equation is PaO2 equals PiO2 minus PaCO2 over R. That's actually the more complicated way of looking at this. The easier way of looking at this is to estimate it with the equation PaO2 equals 150 minus PaCO2 over 0.8. I think that's probably an equation worth knowing. Now, where'd that 150 come from? This is an estimate of PiO2, which is the PO2 of the inspired air. There are two numbers that give rise to that 150. The first number is 713. You take the atmospheric pressure at sea level, which is 760, and you subtract the partial pressure of water vapor at sea level, which is 47, and that gives you 713. Then you have to multiply that by the FiO2, the fraction of inspired oxygen. Normally, the air you're breathing is about 21% oxygen, so the FiO2 is 21%, or 0.21. Then you multiply the air pressure, 713, times the FiO2, 0.21, and that gives you about 150. So that's a rough estimate of your PiO2. And then 0.8 is an estimate of R, which I'm not going to get into. Just memorize the equation PaO2 equals 150 minus PaCO2 over 0.8, and you'll be in great shape.
Now, PiO2 isn't always 150. In practice, PiO2 is dependent on two things, FiO2 and atmospheric pressure. So how could you change FiO2? Well, if you were to put a patient on an oxygen mask and you ramp up the oxygen content, or the FiO2, you can get that PiO2 number to go up from 150 to 300, 400, 500. Or if you intubated the patient and gave 100% oxygen, you could get that number up to 700 or so, right? But we don't want to do that for too long, but you could. And then if you were to take somebody to a high altitude where the atmospheric pressure is lower, that 150 number would come down. At high altitude, FiO2 is the same, but atmospheric pressure is lower. So again, the PiO2 is dependent upon FiO2 and atmospheric pressure.
The other thing to note here is that as you increase your CO2 in this equation, what happens to oxygen? As you increase CO2, your alveolar oxygen is going to decrease. You can see it in the equation, and it just has to decrease. We're subtracting PaCO2 from 150, so as PaCO2 goes up, PaO2 is going to go down. And the converse is true as well. As CO2 goes down, PaO2 is going to go up. But more importantly, and more clinically relevant here, is how do we measure oxygenation in a patient? How do we determine how successful a patient is at oxygenating themselves? Well, there are two measures of oxygenation that you should be familiar with. The first one is the AA gradient. It's the alveolar oxygen tension, P big AO2, minus the arterial O2 pressure, P little AO2. This is a gradient, so you're subtracting. Sometimes you'll hear about the AA ratio, where you take the same numbers and you divide them. But this is the AA gradient, which is what you need to remember. So you take the pressure of oxygen in the alveoli, which we calculated from the alveolar gas equation, and then you subtract the arterial oxygen pressure, which you measure on your ABG, and that's your AA gradient. The AA gradient is normally a pretty small number, around 10 to 15. That's the difference between the oxygen content in the alveoli and the oxygen content in the blood. Under normal circumstances, the oxygen should readily diffuse from the alveoli into the arterioles, so there really shouldn't be much gradient at all. So the AA gradient is a low number. If the gradient is very large, that means there's a problem with that gas exchange. So what kinds of things will give you an increased AA gradient? Well, increased AA gradient can be due to shunting or VQ mismatch, where the blood isn't making it to the alveoli. You can have increased AA gradient from something like pulmonary fibrosis, which causes a diffusion limitation. A diffusion limitation means that something has thickened the diffusion barrier between the type 1 pneumocytes and the basement membrane and the endothelial cells. And it prevents gases from diffusing freely across the barrier, so you can't exchange gas very well. Another factor that can increase the AA gradient is an increased FiO2. If you increase the FiO2, the fraction of inspired oxygen, from 21% up to, say, 50%, that's going to change the AA gradient, because even though you put a ton of oxygen in the alveoli by increasing the FiO2, there's still a functional limit to how much oxygen can actually transfer from the alveoli to the blood. So when you increase FiO2, you're going to flood the alveoli with oxygen, but the blood is not going to be flooded with so much oxygen. So that's going to change the AA gradient artificially. And then finally, advancing age will change your AA gradient as well. As you get older, the AA gradient will increase slightly, just a little bit. Now, just remember, the high AA gradient is usually bad news. That's the fundamental thing here. So that's the alveolar gas equation and the AA gradient. But keep in mind, calculating the AA gradient is kind of cumbersome. Measuring arterial O2 is easy, just check an ABG, but calculating alveolar O2 is a little more involved. So the second way to measure oxygenation is to use the PaO2-FiO2 ratio. This is the arterial O2 divided by the FiO2. Remember, for a gradient, you're subtracting. For ratios, you divide. Again, the FiO2 is going to be related to the alveolar O2 in some way. The normal value for this ratio is 300 to 500 millimeters mercury. Less than 300 indicates a gas exchange deficit. Less than 200 is severe hypoxia, which is something you might see with ARDS, acute respiratory distress syndrome.
Next, let's talk about oxygen deprivation. There are basically three ways that your body can be deprived of oxygen, which are listed in the study guide. You can have inadequate PaO2, so that not very much oxygen is dissolved in the blood, and that's called hypoxemia, hypooxygenemia, low oxygen in the blood. Second, you can have inadequate oxygen delivery to the organs and the tissues. So there's plenty of oxygen in the blood, but the oxygen just doesn't get into the tissues like it should. This is low oxygen at the tissue level, so this is tissue hypoxia. Or third, you can have inadequate perfusion, some vascular problem that chokes off blood flow to the tissues and impairs oxygen delivery that way. So let's think about which diseases will fall into each of these three categories. The first category was inadequate PaO2 or hypoxemia. So if you're at high altitude or if you're simply hypoventilating, maybe from an overdose of morphine, you're going to have low PaO2, but the AA gradient will be normal. The problem here is that you're just not getting much oxygen into the alveoli in the first place. But if you had pulmonary fibrosis, the AA gradient will be high. The oxygen can get into the alveoli, but there's fibrosis and thickening of that gas diffusion barrier, so the oxygen is just stuck in the alveoli and it can't diffuse into the blood. A right to left cardiac shunt will also give you an increased AA gradient because a significant amount of the deoxygenated venous blood is being shunted through the systemic arterial circulation. It's never really getting to the pulmonary capillary beds in the alveoli at all. So again, there's plenty of oxygen in the alveoli, but it never gets to the blood. And then a VQ mismatch will also give you a high AA gradient. We'll talk about VQ mismatch in the next video, but it's essentially another form of shunting blood away from the alveoli. So one more time, in all three of these, there's a big drop-off between the amount of oxygen in the alveoli and the amount of oxygen in the blood, and that gives you a high AA gradient. Very, very important concept. Our second way that the body can be deprived of oxygen was inadequate oxygen delivery to the tissues. So obviously, if you have hypoxemia or decreased oxygen in the blood from any of those things we just listed, like pulmonary fibrosis or a right to left shunt, then you're not going to be delivering much oxygen to the tissue. So hypoxemia ultimately results in tissue hypoxia. Now anemia kind of does the same thing, not because it affects the oxygen dissolved in the blood, but anemia affects the amount of hemoglobin that's available to carry oxygen. We've been over that. We've also talked about carbon monoxide poisoning and carboxyhemoglobin. We said that hemoglobin will preferentially bind to carbon monoxide if it's available, so that will decrease hemoglobin's availability to carry oxygen. So just like with anemia, if there's less hemoglobin available to carry oxygen, there's less oxygen being delivered to the tissues. And if you had heart failure and low cardiac output, you could have perfectly normal amounts of oxygen in the blood, but the pump is failing so that the blood isn't being delivered to the tissues. It's like if you check your mailbox and it's empty. Is it empty because the mailman hasn't come yet? Or is it empty because the mailman came and there was just no mail for you in his bag? With anemia and carbon monoxide poisoning, the mailman already came. The heart delivered blood to the tissue. There was just no oxygen, no mail to deliver. With low cardiac output, there's plenty of oxygen or mail, but the delivery system just isn't getting it there. And then the third way that the body can be deprived of oxygen was inadequate perfusion or ischemia. So this might be due to some obstruction of an arterial flow, like with an MI or a stroke. That would be like a roadblock that's keeping the mailman from getting to your house. Or it could be due to reduced venous drainage, which would be something like a traffic jam on your street that's keeping the mailman from getting to your house. You can see him right there, 5 houses up the road, but there are a dozen cars in his way and he just can't get through. Again, there's plenty of oxygen in the blood, but it just can't get to the tissues that need it. This is pretty basic stuff, and I don't think you need to focus on memorizing these groupings of diseases. But you should make sure that for each of these disorders, you can reason out the underlying physiological problem, whether it's going to cause a normal AA gradient or a high AA gradient. Because at some point, you're going to be on an ICU rotation. You're going to have a patient that's not oxygenating very well. And you're going to calculate the AA gradient and use that to figure out what the underlying problem is. So this is a very clinically relevant point. It's also a very good PIMP question. All right, now you're ready to work through the end of session quiz, and then we'll go over the answers together. First question, what's the normal value for an AA gradient? It's 10 to 15 millimeters mercury. And then what might an elevated AA gradient indicate? It can indicate high FiO2 from supplemental oxygen. It can indicate shunting of blood, pulmonary fibrosis, or something else that impairs gas diffusion, VQ mismatch, and also advanced age. Next, a 42-year-old woman with fibroids is chronically tired. What's the most likely diagnosis, and what changes have occurred in the oxygen content and oxygen saturation? So the most likely explanation here is that she's anemic because she's bleeding from her fibroids. The most common complication of uterine fibroids is excessive uterine bleeding. And that ultimately leads to iron deficiency anemia, and that's going to cause chronic fatigue. She just doesn't have as much hemoglobin to carry oxygen. So then the answer to the second part of the question about the changes in oxygen content and oxygen saturation, her PaO2 will be normal. That's oxygen that's dissolved in the blood. That's not what the question is asking. The question asks about oxygen content. Well, because her hemoglobin is low, the total oxygen content in the blood is low. However, oxygen saturation will be normal. Even though her hemoglobin is low, the hemoglobin she does have works just fine. Each hemoglobin molecule is going to be saturated normally. And the last question, a patient is shown to have hypoxia, and a chest X-ray reveals an enlarged heart. So what's the most likely cause of the hypoxia? So the enlarged heart would suggest heart failure. So this patient might have peripheral tissue hypoxia because the cardiac output isn't high enough to get the oxygenated blood out to the body. Or he could be hypoxemic because he isn't delivering blood to the lungs to pick up the oxygen. All right, that's it for this video. I'll see you soon.
It's time for another warm-up. Let's get going. First question here, which neurodegenerative disease is associated with each of the following statements? So first we have senile plaques, we have neurofibrillary tangles, that's going to be seen in Alzheimer's disease. Presents at birth as floppy baby, so this is Wernicke-Hoffmann disease. Lewy bodies, that's going to see in Parkinson's disease, diffuse Lewy body dementia, and the type of Alzheimer's disease that is subcategorized as Lewy body type. So it's a neurofibrillary tangle and plaques and the Lewy bodies all at once. Next, what is the mechanism of action of infliximab? So antibody that binds to TNF-alpha, preventing it from binding to its receptor. Next question. A patient with multiple sclerosis is determined to have internuclear ophthalmoplegia. What physical exam findings would be expected in this patient? This one's a little tricky. So on lateral gaze, the abducting eye has nystagmus. and the adducting eye is unable to adduct. In other words, there is medial rectus palsy on the affected side with lateral gaze, but when you test convergence, convergence is normal. So that medial rectus palsy only shows up during lateral gaze, not with convergence. All right, that's it for the warm-up. Let's get to that lecture now.
No, you are funny. Just try to be a little more likable. No, listen, I gotta go. Dr. Lewis. In this video, we're going to wrap up pulmonary physiology by talking about ventilation and perfusion. This is going to be a short video, but it's important to recognize that oxygenation and ventilation are independent things, although they do work together. Ventilation is the process of moving gas from the outside of the body into the alveoli, and then oxygenation has to do with getting oxygen from the alveoli into the blood. So it's entirely possible to ventilate without oxygenating. You need to recognize that, again, those are two independent factors. It's going to be a big help when you get to the ICU rotations. You start learning about how to manage a patient on a ventilator, but you're not going to be expected to know how to manage a vent for this exam. So one thing you will be expected to understand is VQ mismatch. We mentioned VQ mismatch a couple times in passing without really stopping to talk about what it means. So VQ mismatch is about a 3 or 4 star topic. In a perfect world, ventilation is perfectly matched to perfusion. V is ventilation and Q is perfusion. We sometimes talk about the VQ ratio, which is V divided by Q. Now ideally, ventilation and perfusion are perfectly matched, so the VQ ratio equals 1. Take a breath, and everywhere that air goes in your lungs is well perfused so that you have good exchange of gas. That's ideally what you want, but functionally, that's not what you get. In reality, some parts of the lung are better perfused than others. For instance, gravity is going to pull more blood down to the bases, so perfusion is better in the bases than in the apices. Now, we can sort of divide the lung into 3 zones. In the apex of the lungs, gravity is working against blood flow, and perfusion is relatively decreased. This means that you're wasting a lot of the oxygen that's going into those apical alveoli. You're putting air into those alveoli, but because there's not much perfusion up there, you're not getting good, efficient gas exchange. So your V, or ventilation, is very high, and your Q, or perfusion, is low, and the VQ ratio is greater than 1. This is wasted ventilation. This is part of that physiologic dead space we talked about earlier. Then, down in the base of the lung, you have wasted perfusion. Gravity is pulling more blood into the lung bases. So much blood, in fact, that you can't ventilate well enough. So the VQ ratio is less than 1 in the lung bases. This is called shunting. You have venous blood that's leaving the lungs, headed back to the heart without being adequately oxygenated because there's just not enough oxygen to go around. So that pulmonary venous blood is coming out deoxygenated. It's as though that blood never went through the pulmonary capillary bed at all. We imagine that it was just shunted right past the lung. Now, not only is perfusion greater at the base of the lung, but ventilation is also relatively greater at the base than at the apex. That's worth noting. It's not the case that at the apex you have excess ventilation. It's really, you just have very poor perfusion up there. So, if you were able to measure the amount of oxygen coming out of the alveoli when you exhale, that would be oxygen that never made it into the blood. And if you could somehow compare the oxygen coming from the apex versus oxygen coming from the base of the lung, there would be less oxygen in the air exhaled from the lung base than from the apices. The air from the apices still has a lot of its oxygen since it's not participating in gas exchange very efficiently. So this explains why tuberculosis prefers the apices of the lungs, because there's more oxygen to be had up there. Now, when you exercise and you increase cardiac output, you actually get some vasodilation of the capillaries in the apices. So the VQ ratio goes down towards 1, so you're no longer wasting all that ventilation because your perfusion increases in that area. So what do these VQ ratios tell us? What good are they? Well, when VQ approaches 0, we're talking about low ventilation and high perfusion, and this is seen with airway obstruction. Maybe the alveoli are filled with pus from pneumonia. Maybe they're filled up with pulmonary edema from heart failure. Maybe there's a lung cancer that's obstructing the airway. But whatever the cause, the VQ is approaching 0, and this is referred to as a shunt because that venous blood is coming out deoxygenated. And with shunting, supplementing oxygen and increasing the FiO2 won't really raise the oxygen content of the blood much because that supplemental oxygen isn't getting to the alveoli in the first place. But the reverse is true with high ventilation and low perfusion. In this case, VQ approaches infinity, and this is either blood flow obstruction like pulmonary embolism, or it's physiologic dead space. So you're putting air into parts of the lung that aren't being perfused. So here, supplemental oxygen to increase FiO2 will improve PO2 because the perfusion is going to be rerouted to other areas of the lungs. Remember, the lungs will preferentially perfuse areas that are getting oxygen, so maximizing the oxygen in those areas is going to improve the oxygen content of the blood. Now, lung perfusion isn't just about getting oxygen to the tissues. It's also about eliminating carbon dioxide waste products. So let's talk about CO2 for just a moment. Carbon dioxide is transported from the tissues to the lungs in 3 ways. With oxygen, there were just 2 ways that the blood was transporting oxygen, either dissolved in the blood or bound to hemoglobin. Well, carbon dioxide is actually transported in 3 ways. The most important way is that it's transported as bicarbonate. How does it become bicarbonate? Well, the enzyme carbonic anhydrase is very important in this process. Carbonic anhydrase takes CO2 plus water and makes carbonic acid. The second way is that CO2 is also transported bound to hemoglobin at the N-terminus of the globin. Not at the heme, which binds oxygen, but actually bound to the globin, binding to the CO2. And when the hemoglobin is bound to CO2, we call that carbaminohemoglobin. And then also, some of the CO2 is dissolved in your blood. And that dissolved CO2 is what you can measure with an ABG. Now, in the tissues, CO2 binds to the hemoglobin. We know that the presence of CO2 favors the T form of hemoglobin, that taut form, the oxygen unloading form. Now, when the blood reaches an area that's very metabolically active, there's a ton of CO2 hanging around, waiting to get picked up by the blood. Some of that CO2 enters the red cell and it binds to hemoglobin, and that converts the hemoglobin to the T form and facilitates oxygen unloading. Then, once it gets back to the lungs, hemoglobin starts binding to oxygen and the CO2 is released from the red blood cells. Then finally, one last topic of basic physiology. What happens with exercise? So when you exercise, you're going to increase O2 consumption, and you're going to increase CO2 production from your muscles. You also increase your ventilation rate to meet oxygen demand, so you're breathing faster. The VQ ratio in the apex and the base becomes more uniform, more balanced. Remember, we said that exercise causes those pulmonary capillaries in the apices to dilate, so you're not wasting so much of that available oxygen. You have increased pulmonary blood flow due to increased cardiac output. You have decreased pH during strenuous exercise because your muscles are making lactic acid. And there's essentially no change in arterial PO2 and arterial PCO2, but there is an increase in the venous CO2 content because you're trying to eliminate all that excess CO2 that you're making. Now, those changes are pretty straightforward. You should be able to reason most of that out. All right, now you're ready for the end of session quiz. So take a look at that, and then I'll go over the answers. First question, what is the VQ ratio at the apex of the lung, at the base of the lung, during airway obstruction, and during blood flow obstruction? So the VQ ratio at the apex of the lung is greater than 1, and at the base of the lung, it's less than 1. We also said that during exercise, both of those values are going to go toward 1 because of increased ventilation and perfusion in those regions. During airway obstruction, ventilation is low, and the VQ ratio is going to go toward 0. We call that shunting. And during blood flow obstruction, like a pulmonary embolus, V is much, much higher than Q, so the VQ ratio goes toward infinity. Next, how is CO2 transported from the tissues to the lungs? Remember, 3 ways. It's transported as bicarbonate, it's transported bound to the N-terminus of hemoglobin as carbaminohemoglobin, and it can be transported as dissolved CO2. And the last one, how does CO2 levels in circulation change during exercise? So again, there's no change in arterial CO2 levels, but venous CO2 levels increase. All right, that's it for Pulmonary 5. I'll see you soon.
Let's go over the warm-up. First question, which exotoxin has each of the following characteristics? So inhibits acetylcholine release, resulting in a flaccid paralysis, that's botulinum toxin. Stimulates adenylate cyclase, resulting in chloride and water going into the gut, causing diarrhea. It's both cholera toxin and the heat labile E. coli toxin from enterotoxigenic E. coli. Causes scarlet fever, is the erythrogenic and pyogenic toxins of strep pyogenes. Inactivates EF2, causing pseudomembranous pharyngitis, is diphtheria toxin. And the toxin that blocks the release of the inhibitory neurotransmitter glycine is tetanospasmin from Clostridium tetani. Next, which CD surface marker fits each of the following statements? Displayed only by helper T cells is CD4. Displayed mainly by cytotoxic T cells is CD8. Found on all T cells is CD3. And used to identify B cells is CD19, CD20, and CD21. And the last question, what is the underlying cause of achalasia, and how's the diagnosis made? So achalasia is caused by destruction of the myenteric plexus or Auerbach's plexus, usually in the esophagus, so that the lower esophageal sphincter is unable to relax. And then achalasia is diagnosed with manometry, where you put a pressure sensing device into the esophagus to measure the esophageal pressures, or on barium swallow, you might see that classic bird's beak sign. So now let's move on to the lecture.
In this video, we're going to talk about human physiology in certain extreme environments, including high altitudes, high G-forces, underwater environments, and space environments. These topics are definitely tested on the board exams and have been for years, but this material isn't covered in a lot of review products. If you're interested in reading up on these topics in more detail, there are excellent chapters in the Guyton and Hall textbook of medical physiology. But I wouldn't recommend reading more on these topics in preparation for your test because I'm going to cover the highest yield material with you. Let's start with high altitude environments. What's different about high altitude environments? Well, one is the barometric pressure is different. At sea level, for example, the barometric pressure is 760 millimeters of mercury. At 20,000 feet above sea level, and that's not even the top of Mount Everest, which is around 29,000 feet, but at 20,000 feet above sea level, the barometric pressure is just 349 millimeters of mercury. So that's a lot less than the pressure at sea level. And no matter where you are, the partial pressure of oxygen is 21% of the barometric pressure. That means that the partial pressure of oxygen at sea level is a lot higher than it is in mountainous environments. And the body has to find ways to deal with that lower partial pressure of oxygen. Another difference at high altitudes is the alveolar oxygen partial pressure. At sea level, the alveolar oxygen partial pressure is 104 millimeters of mercury, and going back up to 20,000 feet above sea level, the partial pressure of oxygen in the alveoli goes down to 40 millimeters of mercury, which is much less than at sea level. This makes it a lot harder to breathe and to oxygenate at high altitudes. So how does your body compensate for this lower partial pressure of oxygen at high altitude? Well, it's going to do numerous things. First, you're going to have an acute increase in ventilation. Because there's less oxygen, you have to breathe more to get more oxygen into your system. And as a result of breathing more, you're going to blow off more CO2. We'll come back to that in a second. And in addition to breathing more acutely, you're also going to breathe more chronically. So even as your body employs other mechanisms to adapt to this low oxygen environment, you're still going to be breathing more at that high altitude than you would be breathing at sea level. So there's a chronic increase in ventilation. You're going to increase erythropoietin production. You do that every time you have hypoxia. The erythropoietin comes from your kidney, goes to your bone marrow, and stimulates more hematocrit and hemoglobin concentration in the red blood cells. So whereas a normal hematocrit might be 40 to 45, at high altitude your hematocrit might go all the way up to 65. And whereas a normal hemoglobin might be about 15 grams per deciliter, at high altitude your hemoglobin is going to go perhaps all the way up to 20 grams per deciliter. So you have to have more hemoglobin and a higher hematocrit to capture as much oxygen as you possibly can. You're also going to increase the production of 2,3-BPG. BPG is bisphosphoglyceric acid or bisphosphoglycerate. 2,3-BPG is going to help unload oxygen to your tissues better, so you're going to oxygenate tissues better the higher your 2,3-BPG is. There are also some cellular changes made at high altitudes. You're going to have more mitochondria. Your cells are going to become more efficient at using oxygen. And then the last thing, you're going to increase renal excretion of bicarbonate. When you increase ventilation, that will bring in more oxygen, but you'll also be blowing off more CO2 in the process. And since pH is relative to bicarb over PCO2, whenever you decrease PCO2 and blow off more CO2, the effect is going to raise your pH. So by breathing more, you get a respiratory alkalosis, and your body is going to compensate for this by urinating out bicarb. So you're going to get a respiratory alkalosis with metabolic compensation. Remember this equation? And what is a drug we can use to help patients that are having a hard time with acclimating to high altitudes? Acetazolamide. So make sure you know that for your test. Acetazolamide is a drug of choice for altitude sickness. Let's talk about altitude sickness for a second. There's something called acute mountain sickness, which is due to rapid ascent to high altitude, and then the sickness begins a few hours or up to 2 days after the ascent. So for example, some people that fly into Denver and then drive into the mountains might have some altitude sickness in the first couple of days. So take a look in your study guide. We have a question here. What are the clinical derangements that come about in a patient with acute mountain sickness? Many patients will have headache. Headache is the most common symptom of acute altitude sickness. Many patients will have fatigue, and potentially in extreme cases you can see acute cerebral edema due to hypoxia-induced vasodilation. And acute pulmonary edema may also develop in extreme cases. Now in the lungs, hypoxia causes vasoconstriction rather than vasodilation. So how does that lead to pulmonary edema? Well, the exact cause isn't entirely understood, but it's hypothesized that at high altitude you start out with a more pronounced pulmonary arteriolar vasoconstriction in some parts of the lung compared to others, which means that there are fewer and fewer unconstricted vessels for the blood to go through. That results in increased capillary pressure and local edema. As that process spreads and worsens, you develop clinically apparent pulmonary edema. Then the next question in your study guide. What physiological changes occur during chronic mountain sickness? The first notation is increased red blood cell mass and hematocrit. The red blood cell mass and hematocrit become exceptionally high. The red blood cells are stuffed as much as possible to carry as much oxygen as possible. Then as a result of that, the viscosity of the blood increases and the tissue blood flow decreases. That's the second bullet. Increased blood viscosity and decreased tissue blood flow. The next one is elevated pulmonary artery pressure. Because the pulmonary arteries are constricting in response to hypoxia, whenever there is not enough oxygen, again, the pulmonary arteries constrict, and that's going to raise the pulmonary artery pressure. The next notation is right-sided heart enlargement as a result of this increased pulmonary artery pressure. The peripheral artery pressure begins to fall, and the last notation is congestive heart failure and possibly death unless the patient is moved to a lower altitude. So that's chronic mountain sickness, and that's all we're going to discuss for high altitude. Now let's talk about a few things with aviation and spaceflight. The main thing we're going to talk about is the effects of G-forces on the body. What is a G-force? It's a gravitational force. 1 G is a force that's equal to the pull of gravity pushing a person into his or her seat. And then a negative 1 G is a force that's equal to the pull of gravity pulling a person out of his or her seat. G-force moves blood from one part of the body to another. Positive G's will move blood away from the head and towards the feet. Negative G's will move blood toward the head. So blood is going to go wherever the G-force is going. Look at the study guide again. The question asks, at what positive G-force does a visual blackout occur? Well, blackout occurs at about 4 to 6 G's. And everybody's a little different, but 4 to 6 G's is where you black out due to the force that's pooling blood in the abdomen and in the legs. The blackout occurs because there's insufficient blood return to the heart and insufficient pumping of blood to the brain. There are specialized G suits that apply pressure to the lower abdomen and legs, and these suits can prevent the blackout. Now let's talk about space medicine for just a second. There have been Step 1 questions in recent years that ask you to know a little something about the G-forces experienced by astronauts. The next question in your study guide says, what G-force is achieved during a spacecraft liftoff? Here, G-forces reach 8 and 9 Gs. For this reason, astronauts have to be in a semi-reclining position on takeoff, transverse to the axis of acceleration. If they were upright and experiencing that number of Gs, they would for sure black out as the blood goes to the legs. So that's why astronauts are in that semi-reclining position when they take off. Also, fighter pilots are able to pull 8 and 9 Gs in hard turns because of their G suits. And then the other main thing I want to discuss about space medicine is how the body is affected at zero gravity for a prolonged period of time. This is in your study guide. At zero gravity, you have a decrease in blood volume, you have decreased red blood cell mass, decreased muscle strength and work capacity, decreased maximum cardiac output, and the last notation is loss of calcium and phosphate resulting in loss of bone mass. So that's what happens with a prolonged stay at zero gravity. Now let's talk about deep sea and hyperbaric medicine. The air we breathe contains 21% oxygen and about 78% nitrogen. That's great at sea level and above water, but once a person goes under the water, this high percentage of nitrogen can become a problem. Divers can get something called nitrogen narcosis. Take a look in your study guide again. This question asks, what is nitrogen narcosis? Nitrogen narcosis occurs when nitrogen dissolves into the neural membranes, which causes reduced neuronal excitability. Again, nitrogen dissolves into the neuronal membranes, and the dissolution causes reduced neuronal excitability. Don't confuse nitrogen narcosis with decompression sickness, which we'll cover in a few minutes. When a diver breathing compressed air spends an hour at a depth of 120 feet, because of nitrogen narcosis, the diver will become, first of all, jovial and careless, and then they become drowsy, and then they might start to lose strength and coordination. So nitrogen narcosis looks similar to alcohol intoxication. That's the third notation, loss of strength and coordination. So that's something that can happen when you stay at extreme depths for too long a period of time. Another thing I want to talk about is the bends, or decompression sickness. What happens here is that when you are at depth, which is a high pressure environment, again, nitrogen gas dissolves in the blood. Then when you come up to sea level again, those gases begin to escape the dissolved state and they form actual bubbles that can occlude blood vessels. This disease goes by a few different names, decompression sickness, or the bends, or caisson disease. Then the next question in your study guide is, what are the symptoms of decompression sickness, or the bends? The symptoms include pain in the joints and muscles of the arms and legs, neurologic problems in about 5 to 10% of patients, such as dizziness, paralysis, or syncope. About 2% of patients get something called the chokes. This is where bubbles occlude the lung capillaries, resulting in shortness of breath, pulmonary edema, and possibly death. So that's what decompression sickness looks like. It might be helpful for you to use the mnemonic, the bends, to remember the features of the bends. So BENDS. B is for breathing problems, E is for extremity pain, N is for neurologic changes, and D is for death. So how do you treat the bends? The best thing to do, first of all, is prevent it from ever happening. So how is the bends prevented? The diver must be brought to the surface slowly so that the nitrogen can be eliminated through the lungs by expiration. For example, if a diver is working at a depth of 190 feet for an hour, the diver will need to follow a scheduled ascension to the surface over a 3-hour time span to prevent the decompression sickness. If you do have to treat the decompression sickness, you need to get the nitrogen back out of the gaseous form, back into the dissolved state so that it can travel to the lungs and be exhaled. And the way to do this is with hyperbaric therapy. Hyperbaric therapy is essentially in a high pressure room. Lots of hospitals have these, and there are also portable hyperbaric units as well. I think it's also worth knowing the few other conditions for which hyperbaric oxygen is potentially helpful. You use hyperbaric treatment to treat decompression sickness. You can use it for arterial gas emboli, like the bends we just talked about. And we use it to treat carbon monoxide poisoning. And sometimes, if you have a hard time getting oxygen to a particular part of your body, you can use hyperbaric oxygen therapy to assist in that oxygenation. So hyperbaric oxygen therapy can be helpful in things like gas gangrene caused by the anaerobe Clostridia. Hyperbaric oxygen might be helpful in osteomyelitis. Now, we don't always use hyperbaric oxygen for those conditions, but there may be some benefit in a case-by-case basis. All right, that's it. Go ahead and work through the end-of-session quiz, and then we'll go through those answers together. First question, how does the body compensate for hypoxia at high altitude? The body is going to increase ventilation to get more oxygen. Ventilation will be increased both acutely and chronically. In order to compensate for the respiratory alkalosis that results from increased ventilation, there will be increased renal excretion of bicarbonate. The body will increase its cellular mitochondria so that it uses oxygen more efficiently. Erythropoietin levels will increase, and then red blood cell mass will increase. And 2,3-BPG will be increased, which shifts the oxygen-hemoglobin dissociation to the right, which favors oxygen unloading to the tissues. Next question. How much does the hemoglobin and hematocrit change in a person that has acclimatized to a hypoxic environment for weeks? It goes from a normal hematocrit of 40 to 45 up to 65, and a normal hemoglobin of 15 grams per deciliter up to 20 grams per deciliter. Next question, at what positive g-force does visual blackout occur, and why does this occur? Blackout occurs around 4 to 6 Gs from the force pooling blood in the abdomen and legs, and insufficient pumping of blood to the brain. Next, what physiologically is taking place in decompression sickness? As you ascend from a dive and you move from high to low pressures, gases, primarily nitrogen, that were dissolved in the blood at higher pressure begin to escape the dissolved state. This forms actual bubbles that can occlude blood vessels. Next question. For what conditions is hyperbaric oxygen therapy particularly helpful? Decompression sickness, arterial gas embolism, carbon monoxide poisoning, and then hyperbaric oxygen is also potentially useful for gas gangrene caused by the anaerobe Clostridium perfringens, as well as osteomyelitis. Next question. By what physiological mechanism does acute mountain sickness cause acute cerebral edema and acute pulmonary edema? The cerebral edema is caused by hypoxia-induced vasodilation, and the pulmonary edema is thought to be caused by local vasoconstriction, which increases capillary pressure and forces fluid out of the vasculature and into the lungs, causing then pulmonary edema. All right, so that's it for our discussion of extreme environments. I'll see you next time.
Let's go over the warm-up review. First question, how does the mechanism of type 2 hypersensitivity differ from the mechanism of type 3 hypersensitivity? So with type 2, there are antibodies against self-antigens on the surface of cells. And these antibodies bind to the cellular antigens and then activate complement and attract macrophages, which leads to cellular damage. With type 3 hypersensitivity, the damage is caused the same way with complement and macrophages, but type 3 hypersensitivity is caused by antibodies against soluble antigens. They're found circulating and also in the interstitium. So these antibodies bind these soluble antigens, and then they form antigen-antibody complexes called immune complexes. And those immune complexes are eventually deposited into tissues. Next, after losing his job, a 35-year-old man develops diarrhea and hematochezia. An intestinal biopsy shows transmural inflammation. So what's the most likely diagnosis? Well, transmural inflammation is a huge tip that you're dealing with Crohn's disease here, which can be exacerbated by stress. And the last one, which area of the colon is most susceptible to ischemic damage due to hypotension? The watershed area of the splenic flexure is most susceptible to ischemia because it's supplied by the most distal parts of the arteries. So now let's move on to the lecture.
Hi, I'm David Finkley. I'm a pulmonologist and critical care physician, and I'm here today to talk to you about deep venous thrombosis, pulmonary embolisms, and pneumothoraxes. When you first think of DVTs and pulmonary embolisms, you always have to come up with Virchow's triad: stasis of blood flow, endothelial injury, and hypercoagulable state. With stasis, you think of lack of movement. You have one-way valves in your leg that allow blood to pool if you're stasis or not moving around for long periods of time. The most common time this happens is people take long car rides or long plane rides. One study found that out of Paris, that people who flew over 5,000 kilometers into the Paris airport were more likely to have PEs if they experienced the common symptoms. Hypercoagulable states, you just need to think of women in pregnancy first, and then you have to think of a few other features. If someone's on oral contraceptives over 35, if they're pregnant, or if they have excess estrogens, those are all risk factors, along with the postoperative period. Think of a C-section. Other specific caveats are anyone with cancer, someone with some secondary disease called polycythemia, an inherited hypercoagulable state such as factor V Leiden, and then sickle cell anemia. Endothelial injury is the third component of Virchow's triad. The common things that you see for it are trauma, foreign bodies entering into blood vessels, some type of bacterial infection, or even fractures of certain bones. These three factors, stasis, endothelial injury, and a hypercoagulable state, all make up Virchow's triad. DV symptoms occur mostly with unilateral leg swelling. You rarely see bilateral leg swelling. It's atypical for DVTs. It's normally seen in heart failure. The patient typically experiences warm leg, redness, and when you see this, you measure the size of both legs, comparing the differences. If one leg's grossly larger than the other, your concern for DVT increases. With Homan sign, you dorsal flex the ankle, and that person will experience pain in their calf. If that is present, it becomes concerning for Homan sign and potentially a DVT. The diagnosis of DVT can be done in several ways. If a patient has low risk factors, meaning they don't have a history of cancer, history of pulmonary embolism, trauma, or you don't have other concerning factors on a clinical exam, you can simply get a D-dimer. A D-dimer represents the fibrin degradation products that occurs in a dissolving clot. If you have high probability of a DVT, such as the factors I mentioned previously, you should go straight to ultrasound and skip the D-dimer. And the way you do this is use compression ultrasound to see if the vessel compresses. If the vessel fails to compress, it's concerning for DVT. To prevent DVT, for those that do not have it, you can use sequential compression devices. These devices basically compress the legs. They wrap around the calf and compress the legs intermittently during the day to push the blood flow from the lower extremity of the feet up into the body, acting as the valves would in someone that's immobile. You can use compression stocking devices as well, which are somewhat effective, and the most popular method is using heparin twice a day or 3 times or once a day Lovenox or low molecular weight heparin. The treatment of DVT, if you actually do have it, initially starts with some type of IV therapy or subcutaneous therapy such as heparin, fondaparinux, or low molecular weight heparin. After you start that initial therapy, many people will be transitioned to oral therapy such as warfarin. And warfarin is very popular because it's cheap. But recently, people don't like to check their bloods once or twice a week while they're on warfarin. So the pharmaceutical industry has developed medicines called novel oral anticoagulants. The following are 10A inhibitors. They have 2 groups. They have an oral group and a sub-Q group. The oral group consists of rivaroxaban, apixaban, and edoxaban. They all have XA in it, so it's easy to remember that they are 10A inhibitors. The sub-Q group, represented by fondaparinux, is given via sub-Q injections. Other factors that you can do when you're deciding which long-term therapy to put the patient on is you can decide between warfarin. It's cheap, it's easily reversible, but you have to have frequent lab checks. Novel oral anticoagulants are very useful. The law industry, you'll see a lot of commercials for about suing people because they're not easily reversible. The pharmaceutical industry is trying to find reversal agents, but it's taking time, and very few are available at this date. So you have to decide on the risk-benefit of using these agents. Last is the low molecular weight heparin-based products. And many people don't like them because they have to give a subcutaneous shot each day. The reason we care so much about deep venous thrombosis is because if the clot is released from the leg, it can go into the lung, causing very severe damage in the lung, or if they have a patent foramen ovale, it can actually go across the right atrium into the left atrium and then eventually into the brain for a stroke, and those effects can be catastrophic. When I think of pulmonary embolism, just to give you a little background on people, I think of several famous people. The first one I think of is the Miami Heat. Remember, they had the big 3 a couple years ago: LeBron James, Dwayne Wade, and the most least famous of these people is Chris Bosh. Unfortunately, his career got derailed because he had chronic blood clots, preventing him from working as a basketball player, and his doctors probably have not released him. The other famous person is Serena Williams, the star tennis player who's won multiple Grand Slams. She had an injury to her leg several years ago, and that injury created a DVT potentially that eventually went to her lung. The classic symptoms for pulmonary embolism are pleuritic chest pain, acute shortness of breath. Sometimes you'll see cough, and rarely will see hemoptysis. You can see low-grade fevers, syncope, and even sudden death if there's a large pulmonary embolism. The most common symptoms you typically see are tachypnea and tachycardia. The diagnosis of pulmonary embolisms can be used helpfully with a D-dimer, but that has to be used only in a low-risk patient. You can also get an EKG where you look for the S1, Q3, T3 abnormalities that you classically see. Other things you can do if you don't think you can get a CT protocol, you can have a deep venous thrombosis and assume that it went to the lungs. Chest x-rays are generally normal. If you obtain an arterial blood glass, you see a high A to A gradient. You can also obtain a CT-PE protocol, which is very helpful. Sometimes patients are unable to get a CT scan due to acute kidney injury, and you can't give them contrast. So you do a ventilation perfusion scan. First, they inhaled a radioactive nucleotide, and you can see there's decreased uptake in this picture. Then in the perfusion phase, you inject a contrast to look again to see if there's decreased uptake. If there's a defect in the ventilation phase, you can think about a pneumonia. If there's a defect in the perfusion phase, you think about a pulmonary embolism. Finally, in rare cases, you can obtain a pulmonary angiogram, which is the gold standard by interventional radiology. It's time-consuming, and it's much easier to use the CT-PE protocols today. A venous perfusion scan is used in people with severe renal failure. The idea is it looks for a ventilation defect. If there's pneumonia, that will be present. If there's a perfusion defect, there'll be a pulmonary embolism. Saddle pulmonary embolisms can lead to sudden death due to the large clot burden. The classic treatment for these are thrombolytics to break up the clot and potentially save that person's life. Other treatments for deep PEs are very similar to deep venous thrombosis. You initially start with some type of sub-Q or IV therapy, either heparin, fondaparinux, a low molecular weight heparin, and then you transition to some type of long-term therapy, which I went over for the deep venous thrombosis portion of the talk. Other type of embolisms are fat embolisms. The things you are concerned about are long bone fractures or someone that's had recent liposuction. The classic triad for fat embolisms are hypoxia, neurologic abnormalities, or even a petechial rash. Amniotic fluid emboli happen in postpartum patients, and it's very difficult to differentiate between that and a venous thromboembolism. The most frightening thing about this, it can lead to DIC in these patients. An air embolism also can occur as another subtype of embolism. And they're seen in people who scuba dive, who go from very deep depths to shallow waters too quickly, and the nitrogen bubbles precipitate into the patient's blood vessels. And it's called Cassian's disease or decompression disease. The treatment of choice is moving these patients to a hyperbaric chamber. Unfortunately, this also occurs when we're doing large IV catheters, and it's an iatrogenic complication. It frequently occurs when someone places a central line into the person's neck and air is accidentally introduced. One of the last type of emboli are septic emboli. They typically occur in the setting of endocarditis, and the clot leaves the valve, either the tricuspid valve clots leaving the tricuspid valve going to the lungs, or leave the left ventricle's valve, mitral valve or aortic valve going to the brain or other extremities. Then we'll move on to pneumothoraces. And when I think of pneumothoraces, I think of famous Dallas Cowboy quarterbacks. The recent retired Tony Romo was injured often. And one of his injuries, he suffered a blunt trauma causing a rib fracture. When they did the CT on him, they found he had a very small pneumothoraces from a traumatic injury. When looking for a pneumothorax, one of the quickest ways to determine if one is present is get a simple chest x-ray. And you're looking to see their lack of lung markings all the way out to the periphery. And then if you're able to do that, which you can see on this image, there's a small line with the arrows pointing to it, and that represents the visceral pleura, disconnected from the parietal pleura. And that's a fairly large pneumothorax on this x-ray. On x-ray, one's not able to see a small pneumothorax, so the CT scan offers the definitive diagnostic technique. And you can see on this picture, on the right side of the CT, which is actually on your left, with the black arrows, is a very small pneumothorax. And then on the left side, with the white arrow, you can see a slightly larger pneumothorax, but even that is quite small. There are other types of pneumothorax: primary spontaneous, secondary spontaneous, and then even tension. Primary spontaneous typically occur in tall, thin people who have apical blebs, and you would call them ectomorphs. Secondary spontaneous typically occur in people with either COPD or some type of emphysema, and they have apical blebs as well. You can also see secondary spontaneous pneumothoraces in patients with AIDS and pneumocystis carinii pneumonia or acute respiratory distress syndrome, where they have barotrauma from being on the ventilator. Traumatic pneumothoraces typically occur from a blunt trauma such as a rib fracture like Tony Romo, or a gunshot wound where the bullet enters the thoracic cavity creating a pneumothorax. The physical exam for patients with pneumothoraces, they typically have symptoms on one side with shortness of breath, either chest pain, and the physical exam, they have unilateral breath sounds. You'll have basically no breath sounds. The chest will only expand on one side. They'll have diminished breath sounds when you listen carefully. They'll be hyperresonant to percussion. They have decreased tactile fremitus, and the trachea deviates away from the side of pneumothorax, especially if it's tension. So the last type of pneumothorax is a tension pneumothoraces. Tension pneumothoraces are very scary situations. Basically what happens is you have injury to the lung, which creates a one-way valve. Air can go out into the thoracic cavity during inspiration, but the valve closes during expiration, not allowing air to enter. This creates buildup of air in the thoracic cavity, forcing the lung and the heart to one side of the chest, leading to hypotension and shock, and eventually death if it's not corrected with the proper procedure. To diagnose a pneumothorax, you can use a chest radiograph, which is the fastest and easiest, and you see basically no lung markings on that side of the chest. Sometimes the pneumothorax is so small, you need to do a CT scan to look for small pneumothoraces, but that's typically done only if the patient's very stable. The chest x-ray is probably the mainstay of diagnostic evaluation for pneumothoraces. The treatment, we always put oxygen on people just to provide them some relief. And in the most acute situations, such as someone with a tension pneumothorax, you put a needle decompression. You go above the second rib, and you put a small needle into the pleural space, into the lung cavity to release the tension. After doing this, you need to proceed with a tube thoracotomy or a chest tube. And typically the chest tube is placed on the side of the pneumothorax to relieve the rest of the tension. In patients on mechanical ventilation, you can see a small ET tube in this chest x-ray near the clavicles. And they sometimes will develop a large pneumothorax, which the air will push all the structures of the mediastinum to the right. This leads to circulatory collapse and eventual death if you don't intervene with the chest tube in a timely fashion. In patients with pulmonary embolism, sometimes they have clots called a saddle embolism. You can see the red arrow pointing to this. If they have such a large embolism, this frequently leads to circulatory collapse, and these patients will frequently need thrombolytics to correct the process. Now it's time for the end of session quiz. Please pause the video so you can answer the questions in your study guide. Question number 1. A patient suffered a stroke after incurring multiple long bone fractures in a skiing accident. What caused the infarct? A fat emboli normally does not cross over into the arterial circulation, but can via a patent foramen ovale, or an AV malformation in the lung. Question 2. A patient with recent tibial fracture and no history of COPD or asthma is shown to have hypoxia. The patient's chest x-ray is normal. What is the cause of hypoxia and what disease process does this process mimic? The patient has a DVT from immobility that led to a PE. The classic mimics for this processes are myocardial infarction because they frequently have chest pain. Question 3. A patient comes to the ER after a motor vehicle collision with shortness of breath. A chest x-ray reveals mediastinal shift to the right. What is the most appropriate next step? Immediate lung decompression with a needle on the left side. That's the end of session quiz. Now let's look at some rapid fire facts. Elevated D-dimer. When I see that, I think of DVTs or pulmonary embolisms. Another rapid fire fact is hypercoagulable state, endothelial damage, and stasis of blood. That's Virchow's triad. That's it for this lecture. We'll see you next time.
All right, welcome to Pulmonary 8. First question, what enzyme is inhibited by PPIs? Well, PPIs are proton pump inhibitors like omeprazole, esomeprazole, lansoprazole, and pantoprazole, a whole bunch of these. But all these drugs inhibit the hydrogen-potassium ATPase, which is the countertransporter that puts hydrogen into the lumen of the stomach to make gastric acid and brings potassium into the parietal cell. And the last question, what are the C's of Huntington disease? So you have CAG repeats on chromosome 4 or chromosome 4. You can throw in quarenta to remember that this is typically seen around age 40. It can cause cognitive decline or dementia. And then there's chorea. Remember the old name for Huntington's disease was Huntington's chorea. And then finally you have atrophy of the caudate nucleus. All right, that's it for the quiz. I'll see you next time.
Hi again. I'm going to talk today about COPD and asthma. First off, when you're thinking of this, you need pulmonary function tests. The mainstay of pulmonology for these tests is spirometry. You have them take a deep breath in and then blow all their air out as much as possible. And when you do that, you get an FEV1, which is the amount of air they can blow out in 1 second, and a forced vital capacity, which is the amount of air they can blow out total. This ratio is normally about 80. In patients with a FEV1 to FVC ratio less than 80 is suggested of trouble getting air out or obstructive lung disease. When the ratio of FEV1 to FVC is greater than 80, it's suggested of restrictive lung disease, and they have trouble getting air in. This ratio is not perfect for diagnosing restrictive lung disease. You actually need lung volumes. But if you see a ratio that's very high, it's suggestive of restrictive lung disease. When I think of asthma, I think of famous people with asthma. The first one is John F. Kennedy, Pink, Jessica Alba, and then David Beckham. My wife made me put that one in for all the girls because JFK is so much older than everyone else. The asthma pathophysiology is classically you have increased sensitivity to certain things in the air leading to bronchial constriction that's typically reversible. The beta-2 receptor stimulation leads to bronchodilation. And the classically way this is done is albuterol. And this improves the bronchodilation and possible improvement in the FEV1-FVC ratio. Other pathophysiology features are smooth muscle hypertrophy, leading to hypertrophy of these muscles, and bronchospasm. This bronchospasm can go on to lead to air trapping. Some of the pathology you see in the pathology section of asthma you see are Kirschmann spirals. They're spiral-shaped mucus plug and desquaminated epithelium. They're seen in asthma and obstructive lung disease. And the clinical significance is not understood very well at this time. Another one is Charcot-Leyden crystals. They are associated with eosinophilic inflammation. Classic asthma triggers are certain medications, emotional stress, cold air. If you start exercising a lot, some people have exercise-induced asthma. And then you can imagine living in Los Angeles, all the air pollution people are exposed to. And then if you're in Texas, we're exposed to a lot of allergens with the changing seasons. The classic symptoms for asthma are cough. Sometimes this is the only feature they have, and it's known as cough variant asthma. Most patients will wheeze, have shortness of breath, tachypnea, hypoxia. They typically have a short inspiration and a prolonged expiratory time. When it gets really bad, they purse lip breathe. Sometimes it leads to pulsus paradoxus if it's very severe symptoms, and mucus plugging. So what is pulsus paradoxus? It's an abnormal drop of 10 millimeters of mercury of systolic blood pressure during inspiration. What happens is there's decreased interthoracic pressure leading to increased right ventricle blood return. This causes the right ventricle to compress the left ventricle, decreasing cardiac output to the rest of the body. It's seen in cardiac tamponade, asthmatic patients, and sometimes in patients with severe pulmonary embolisms. Diagnosis for asthma by pulmonary function test is they have a bronchodilator response of 200 cc's increase or 12% increase in the FEV1 or FVC ratio when they're given a bronchodilator. You can also use a methacholine challenge to see if they have a decrease in the pulmonary function test at FEV1 of 20%. Aspirin-induced asthma basically occurs because there's inhibited production of COX-2 by the aspirin. This leads to overproduction of the leukotrienes, and as a byproduct, the patients will have symptoms of asthma, nasal polyps, and aspirin hypersensitivity. When we think of COPD, I first want to think of famous people. Jimmy Fallon doesn't have COPD, but most of you don't know all the famous people before him that did the late night show before him. Jay Leno didn't have COPD, but the most famous person who was the king of late night before all these people and made late night famous was Johnny Carson. And he did the Tonight Show for over 25 years and had countless actors and actresses come on board, and he was the center of the ring and the most famous person for doing this. Unfortunately, he smoked a lot and developed COPD and died prematurely. COPD is due to airway inflammation, and it leads either to chronic bronchitis or emphysema. Chronic bronchitis, the blue bloater, is consistent with chronic productive cough for greater than 3 months for more than 2 consecutive years. It's a clinical diagnosis, not a histological. It can occur before or after they develop airflow limitation, and typically is caused by long-term irritants and infection, and the most likely irritant is chronic smoking. The symptoms for people with chronic bronchitis are wheeze. Some will have crackles. Many of them will be cyanotic, especially if they're hypoxic. They have shortness of breath. They'll develop peripheral edema in the lower extremities. Some will develop pulmonary hypertension, hypoxia due to shunting. They'll have carbon dioxide retention, and they'll develop secondary polycythemia. In patients with chronic bronchitis, they have hyperplasia of both the goblet cells and submucosal glands. When you see this hypertrophy, you can actually measure it using something called the Reed index. The Reed index is when you measure the thickness of the glands between B and C, and that's the size of the goblet cells or the submucosal glands, and then you divide that by the thickness of the walls between A and D, the distance between the epithelium and the cartilage. And if this is greater than 50%, as representative of an elevated Reed index. When you think of emphysema in a normal person, they will have a normal anterior to posterior diameter. In patients with emphysema, they have air trapping, and this anterior posterior diameter gets increased, and it leads to barrel chesting, which you can see in the picture. Emphysema will have flattening of the diaphragm, and again, you can see in the lateral view of this chest x-ray increased AP diameter, and prominent central pulmonary arteries. The acids of patients with emphysema are the most abnormal things. The normal acidness represents the terminal bronchial, which consists of going from proximal to distal, the respiratory bronchioles, the alveolar duct, the alveolar sacs, and then the alveoli. Central acinar emphysema has damage to the respiratory bronchioles, and the rest are spared. And this is represented in someone who smokes. Pan-acinous emphysema is represented by someone with alpha anti-1 trypsin, and this is damage to the whole acinus. In patients with central acinar emphysema, it's normally from cigarette smoking, as I mentioned, and it involves the upper lobes, where pan-acinous involves the lower lobes and is consistent with alpha-1, as I just mentioned. Patients with emphysema, you also have a classic feature of a pink puffer. They have pursed lip breathing to prevent the airway collapse. They typically do not have cyanosis and actually are very red normally. They have severe shortness of breath and a risk for spontaneous pneumothorax from a rupture of a blood. Pink puffers with emphysema typically have low DLCO. They have increased compliance because of the loss of elastic fibers in their lungs. Alpha-1 antitrypsin is classic for emphysema of the lungs, and sometimes you'll even see cirrhosis of the liver. These patients typically have early onset emphysema in the 20s and 30s, especially if they smoke. Typically, emphysema is delayed into patients' 50s or 60s, and it's mainly due to the inability of the alpha-1 to be present to prevent the breakdown of elastase in the lungs. Alpha-1 typically protects against this, and these elastase damage the lung when they're unopposed. The classic features of alpha-1 antitrypsin, you have emphysema in the lower lobes, which you can see here with pan-acinar emphysema. Bronchiectasis is another feature, lung disease. Bronchiectasis is most easily defined on a CT scan. You can see in the middle of the screen, you can see the division of the right and left mainstem bronchi in the center of the screen. As you go out from the center of the screen on the right mainstem bronchi, you can see the airway stays the same size and doesn't decrease in size. In a normal person, the airway should slowly get smaller and smaller, but in this patient with some type of bronchiectasis, the airway stays the same size. This classic symptoms for bronchiectasis can be found based on a TV show called The X Factor. You all remember Simon Cowell when he was on American Idol, or his news show, America's Got Talent. He had a lady try out on this show between those two shows called The X Factor. And she tried out, and unfortunately she didn't do very well. After she tried out, only he would say, "You have a very weird sounding voice. Are you aware of that? It's like someone else is in there." And then his co-judge, Sharon Osbourne, piled on, "You need to see a doctor." So the lady actually listened to Dr. Cowell and Dr. Osbourne's advice. And she went to the doctor and actually had bronchiectasis. It's kind of amazing that they're so in tune to the way people's voices should sound that they were able to recognize severely abnormal voice. The classic features for people with bronchiectasis is more common in women. They have productive cough, increased sputum production. Many of them will have sinus disease. It's rare for them to have hemoptysis, and they have daily sputum production. The shortness of breath is largely based on the degree of pulmonary function test decline. The pulmonary function tests tend to be obstructive, and the most common causes for bronchiectasis are allergic bronchopulmonary aspergillus, a fungus creating an inflammatory response. You will see central bronchiectasis, and the classic buzzword for this is central bronchiectasis or finger and glove, where you see a thick airway with mucus impacted in it. Cartager syndrome, where you have reversal of the organs, where the heart will be on the right side instead of the left. Most common cause of bronchiectasis is cystic fibrosis. And then another one that you will often see is primary ciliary dyskinesia. Now that we've finished the lecture, it's time for a quiz. So do the quizzes and then return to the video when you're ready. All right, are you ready now? What are the hallmark characteristics of obstructive lung disease on pulmonary function tests? The hallmarks on this are, it's difficulty getting air out, they have increased total lung volumes, and their FEV1 to FEC ratio is typically less than 80. What are the hallmark characteristics of restrictive lung disease on pulmonary function tests? They have decreased lung volumes, and their FEV1 to FEVC ratio typically are increased. They have a high ratio, and they generally cannot get air in. What is the Reed index? If 50% of the bronchial wall is composed of mucus-secreting glands, there's an elevated Reed index. The ratio between the thickness of the submucosal glands and the distance between the epithelium and cartilage. How does emphysema caused by smoking differ from emphysema caused by alpha-1 antitrypsin deficiency? Smoking is typically central acinar, and alpha-1 is typically pan-acinar. That's the end of session quiz. Now let's do some rapid fire facts. A blue bloater is someone that's hypoxic, hypercapnic, and has chronic bronchitis. A pink puffer is someone that has dyspnea, hyperventilation, and emphysema. And finally, a Kirschmann spiral sheds epithelia from mucus plugs. It's found in someone with asthma. That's the end of video for COPD and asthma. See you next time.
Let's go over the warm-up review. First question, what disease is associated with each of the following antibodies? Anti-mitochondrial antibodies are seen in primary biliary cholangitis. Anti-TSH receptor antibodies are found in Graves' disease, where they actually stimulate the receptor. Anti-centromere antibodies, remember C for centromere and C for crest scleroderma. Anti-basement membrane antibodies are Goodpasture syndrome. And then for the anti-neutrophil cytoplasmic antibodies, or ANCA, there are several different types. C-ANCA is seen in granulomatosis with polyangiitis, or Wegener's granulomatosis. And then P-ANCA is seen in eosinophilic granulomatosis with polyangiitis, which is also known as Churg-Strauss syndrome. It's also seen in microscopic polyangiitis, pauciimmune crescentic glomerulonephritis, primary sclerosing cholangitis, and ulcerative colitis. And the last one, what is the female homologue to each of the following male structures? So the homologue of the corpus spongiosum is the vestibular bulb. The homologue of the bulbourethral glands are the vestibular glands, or the Bartholin glands. And the homologue of the ventral shaft of the penis is the labia minora. Now let's get started with the lecture.
Hi there again. Today we're going to talk about pulmonary medications. So when we think of asthma, the mainstay for acute exacerbation is albuterol and levoalbuterol. The mechanism of action is they work on the beta-2 receptor, leading to smooth muscle relaxation of the bronchi. They don't have any anti-inflammatory component, and they're an inhaled drug of choice for acute exacerbation. And you can give them either a nebulizer, through a machine, or in quick inhaler. And the side effects you classically see are jitteriness and tachycardia. Sometimes when you give this medicine to kids, you'll see heart rates into the 150s. Levoalbuterol is a stereoisomer of albuterol and may have less beta agonist crossover effect, so they should have less tachycardia and less jitteriness. In my practice, I don't always see it makes that much of a difference. Long-acting beta agonists are formoterol and salmeterol. They're the mainstay of COPD treatments for patients. For asthma, you can use these, but you need to be on an inhaled corticosteroid. Otherwise, if you do them alone, they have an increased risk of respiratory complications when given alone. So we always combine them with inhaled steroids. And they work very similar to the short-acting beta agonists, but they have a longer effect. Steroids, they basically are inhaled for patients, and the idea behind giving inhaled steroids is to decrease the inflammation of patients with asthma or COPD. They inhibit the cytokine synthesis, inhibit TNF-alpha production, and they're generally not helpful for acute exacerbations. And they're the first line of treatment for asthmas who fail the short-acting beta agonists. And the most common ones we give are fluticasone, budesonide, and beclomethasone. We can also give systemic steroids when people are exacerbating, and there's really no difference in whether you give them oral or IV. Cromolyn is something rarely used today. I've actually only seen it used once, and that was about 10 years ago. The idea is it prevents the release of histamine and other inflammatory markers from mast cells. And the goal is to prevent bronchoconstriction and inflammation by preventing its release. Muscarinic antagonists, the most common ones are ipratropium and tiotropium. Tiotropium is long-acting and ipratropium is short-acting. They work by blocking the muscarinic receptors. They decrease the overall vagal or parasympathetic tone in the lungs, thereby causing a smooth muscles relaxation, leading to bronchodilation. They're mainly used in COPD patients, but in severe asthma, ipratropium can be used as an initial rescue, and for tiotropium, it can be used for patients that have severe asthma that have long-acting components, and it hopefully will help them. Let's go over the anti-leukotrienes. Xylutin is a 5-lipoxygenation inhibitor. It blocks conversions of arachidonic acid into leukotrienes. Leukotrienes are responsible for chemotaxis. They increase secretion and bronchospasm. Xylutin also can cause hepatic toxicity. Zafilucast and montelukast block the receptors, preventing the bronchogenic and chemotaxic effects of leukotriene D4. These are helpful in aspirin and allergic-induced asthma. Methylxanthines, the one most well-known is theophylline. It can cause bronchodilation by inhibiting the phosphodiesterase, increasing cyclic AMP, and decreasing hydrolysis. Unfortunately, it has a very narrow therapeutic window, and the side effects are tremor and tachycardia. If one overdoses on this medicine, you can use a beta blocker. And if the levels are severely high, they can even cause seizures. And it also blocks the action of adenosine. The expectorants that we use for most of our patients are guaifenesin and N-acetylcysteine. Guaifenesin thins the mucus, but you need very elevated doses to be effective. It doesn't suppress cough, and typically you have to add dextromethorphan for this to suppress the cough. N-acetylcysteine is used for several things. Tylenol overdose, you can either use it orally or IV. You can use it for contrast-induced nephropathy, but this has fallen out of favor because of countless studies showing it's not effective, but you should know that. And also it can be used as a mucolytic that breaks the disulfide bonds in some patients with obstructive lung disease. Anti-IgE monoclonal therapy, olizumab. The medicine is primarily effective in patients with severe asthma with an allergic component. It's generally safe for patients who've failed inhaled steroids and LABAs and have elevated IgE levels. It works by binding to the IgE in the serum and blocking the receptor. The ultimate goal of this is it reduces exacerbation and the use of rescue inhaler in these patients. And the times I've seen it used, I've found it to be very effective in our patients. The first generation H1 blockers are diphenhydramine, dimenhydrinate, and chlorpheniramine. They're very sedating because they penetrate the CNS very easily. They're clinically used normally for allergies, motion sickness, and sleep aids. The toxicity sometimes are dry mouth, delirium in elderly patients. They also sometimes will even have anti-muscarinic effects and anti-alpha adrenergic effects. The second generation H1 blockers, loratadine, fexofenadine, desloratadine, and cetirizine, are mainly used for allergy. They do not cross the CNS as much, and they're much less sedating. High dose of cetirizine can be sedating in some patients. Go to your study guide, and we're going to go over a couple other uses of antihistamine medications. One of which is cryoheptadine. It's the antidote for serotonin syndrome. It also can be used as an appetite stimulant for underweight pediatric patients. Promethazine is largely used for nausea and vomiting prevention. Hydroxyzine can be used for sedation, rash or itching. And another one is meclizine, used for vertigo. So if you're on a ship, you may need some meclizine. And these are not used largely for allergic rhinitis. Cough suppressants. Opioids are very commonly used for this, but doctors are trying to prescribe less opiates in general. And they basically work by decreasing the CNS sensitivity of the cough receptor, and they're seen in many cough syrups. Dextromethorphan is a synthetic derivative of morphine that has no analgesic properties, but it can cause constipation, and we use it in most over-the-counter cough suppressants. And used in high doses with a combination of certain medicines, it can cause serotonin syndrome. So nasal decongestants, the most common ones are phenylephrine and pseudoephedrine, and they work by working on the alpha adrenergic agonist, causing constriction of the dilated arterioles, reducing airway resistance, reducing swelling, and nasal congestion. And you can either take it orally or via aerosol. The problem with these medicines is if you take them long-term, they can cause rebound congestion when you stop taking them. Pulmonary hypertension is becoming a disease that's being seen more across the country. They have several new medicines coming out, and they're being tested on the boards more often. The first one that we see most often are eprostenol and iloprost, and they work directly by vasodilating the pulmonary vascular beds, reducing the pressures in those systems. The side effects are jaw pain, flushing. Most of the patients are very red when you see them. You have bosentan, which antagonizes the endothelial receptor 1, and the major side effect is hepatotoxicity. The next one is sildenafil, and this inhibits phosphodiesterase 5, increasing cyclic GMP, thus prolonging the effect of nitric oxide. You will also see this medicine and medicines that work on this process used for erectile dysfunction. And the thing to remember is if someone's on sildenafil or tadalafil, you should not be giving them nitroglycerin for chest pain or any other reasons because you have unsafe drop in their blood pressure. Now it's time for a quiz. Take a break, do the quiz, and then we'll get back to you. What asthma medication fits each of the following statements? Preventive medicine of choice for mild persistent asthma. Inhaled corticosteroid. Inhaled treatment of choice for acute exacerbations. A short-acting beta agonist. A medicine that has a narrow therapeutic index and it's the drug of last resort. Theophylline. Blocks conversion of arachidonic acid to leukotriene. Xylutin. Inhibits mast cell release of mediators used for prophylaxis only, cromolyn. Inhaled treatment that blocks muscarinic receptors, ipratropium and tiotropium. And inhaled long-acting beta agonist, formoterol or somaterol. Blocks leukotriene receptors, zafirlukast and montelukast. Which medication taken long-term can result in rebound nasal congestion? Pseudoephedrine and phenylephrine. Thank you for your time today, and I appreciate your patience.
Dude, are you allergic to the gym or something?
I don't think so. Why?
Because every time you work out, you get all swole up. Speaking of allergies, did you know that Montelukast is indicated for treating allergic rhinitis in addition to asthma? What's the difference between the mechanism of action of Montelukast and the mechanism of Xylutin? Xylutin inhibits the enzyme 5-lipoxygenase, so it blocks the conversion of arachidonic acid into leukotrienes. But Montelukast and zafirlukast work by inhibiting the leukotriene receptor. Montelukast is approved for use in children over 2 years old, but zafirlukast is only approved for children over 5. Roger, your test results came back in, and I'm afraid it doesn't look good.
Give it to me straight, Doc.
You got a bad case of scoliosis.
It's time for the 3-question winner for Pulmonary 10. Let's get going. What portion of the brachial plexus is injured in Herb Duchenne palsy? What are the symptoms? So the brachial plexus injury is at C5 and C6 roots, or the upper trunk of the brachial plexus. The patient would have symptoms of loss of abductors, loss of the lateral rotators, and loss of the biceps. So the arm is left in a adduction, medial rotation, and pronation. Next question. What is the most common salivary gland tumor? So this is the pleomorphic adenoma, and luckily it's benign. Next, what are the different sinuses that can become infected and cause sinusitis? So we have the maxillary sinuses, the frontal sinuses, the ethmoidal air cells or ethmoid sinuses, which are kind of in between the eyes as well, and then the sphenoid sinuses, which are deep to the ethmoid air cells behind the eyes. All right, guys, that's the end of the warm-up. Let's get to that lecture now.
In this video, we're going to talk about restrictive lung diseases, which includes things like pulmonary fibrosis and pneumoconiosis. Now, there are two main ways the lungs could be restricted. There could be a problem with the mechanics of breathing because the lungs aren't compliant and they don't fill up with air very well, or because the diaphragm and other respiratory muscles are weak. And the other type of restriction is that there's some type of interstitial process that impairs gas exchange through the alveoli. We call this a diffusion limitation. There's something that prevents gases from diffusing from the alveoli into the blood. But in either case, restrictive lung disease results in decreased lung volumes, an increased work of breathing, and inadequate ventilation and/or oxygenation. Now, restrictive lung disease will cause decreased lung volume on PFTs. So the total lung capacity will be low and the forced vital capacity will be low. Now, on the left is the normal lung volume graph, and on the far right is the patient with restrictive lung disease. So the pink line represents the total lung capacity, and you can see that in restrictive lung disease, it's much lower than normal. But when you look at the FEV1 to FVC ratio, that's 80% or higher. These patients do most of their forced expiration in the first second, which is very different from obstructive lung disease like COPD or asthma. Those patients have a reduced FEV1 to FVC ratio, which you see in the middle. So what kinds of disorders interfere with normal breathing mechanics? Well, it could be muscular disorders like myasthenia gravis, Guillain-Barré syndrome, or poliomyelitis. So muscle weakness means difficulty breathing. Or it could simply be a structural problem. Severe kyphosis or scoliosis or various chest wall deformities can potentially restrict the lungs from expanding normally. Likewise, morbid obesity can make it hard to expand the lungs because there's an extra layer of adipose tissue that's compressing the chest and restricting the lungs. Another structural disorder would be a diaphragmatic hernia that simply takes up space inside the thoracic cavity so that the lungs can't expand. So all these disorders restrict the volume of air that enters the lung. But with all of these, the AA gradient is normal. The gases that do enter the lungs and reach the alveoli can diffuse into the blood normally, so the AA gradient is going to be normal. But most of the restrictive lung diseases we're going to talk about are interstitial lung diseases that reduce the gas diffusing capacity of the alveoli. And that results in an increased AA gradient. And interstitial lung diseases aren't the only things that cause an increased AA gradient. Things like pneumonia and lung abscesses and even lung cancer can do it as well. But we're going to focus on just the interstitial lung diseases right now. And there are a ton of them. So we're really only going to review the ones that you're most likely to see on your exam, starting with acute respiratory distress syndrome, or ARDS. ARDS can be triggered by just about anything that severely damages the lungs, including things like shock, infection, toxic gases, aspiration, high concentrations of oxygen, pancreatitis, heroin overdose, sepsis, trauma, uremia, and amniotic fluid embolism. Lots of things that can potentially put somebody in the ICU could potentially lead to ARDS. Now, these initial insults result in the recruitment of inflammatory cells to the lung, and those inflammatory cells generate inflammatory mediators as well as oxygen-free radicals. Then, due to the initial insult plus these inflammatory changes, you end up with damage to both the endothelial cells in the pulmonary capillary bed and also damage to the type 1 alveolar epithelial cells. This is referred to as diffuse alveolar damage, which in turn leads to more inflammation and more alveolar damage. So ARDS is a vicious cycle of inflammation that's very difficult to stop. And at the same time, that damaged capillary endothelium becomes leaky, and blood and protein start to leak into the interstitium, and you have what amounts to pulmonary edema, and this really hinders gas diffusion. There's also neonatal respiratory distress syndrome, which is similar pathologically, but here the inciting event is surfactant deficiency. Pulmonary surfactant is a substance, mainly dipalmitoyl phosphatidylcholine, that's secreted by type 2 pneumocytes to reduce surface tension in the alveoli and allow the alveoli to expand and fill with air. Now, these type 2 pneumocytes mature around 34 weeks of gestation. So a premature neonate who's born before 34 weeks is at increased risk for surfactant deficiency, which results in increased surface tension and collapse of the alveoli. Now, other risk factors for NRDS, besides being premature, include maternal diabetes and also cesarean delivery. So, if you need to deliver before 34 weeks, you can give the mother steroids like betamethasone or dexamethasone for 48 hours prior to delivery. And that's going to help to mature those type 2 pneumocytes in utero and reduce the risk of neonatal respiratory distress syndrome. Now, because these neonates with NRDS may end up on a ventilator, you should also know that oxygen in high doses can be very toxic, and it's associated with things like retinopathy of prematurity, intraventricular hemorrhage in the brain, and bronchopulmonary dysplasia, which is a chronic lung disease in which there's disruption of lung development and ongoing inflammation. Another type of interstitial lung diseases are the pneumoconioses. Now, pneumoconioses can be very high yield for this exam. Some students have reported 3 or 4 questions on these, so this might be a 4 or even a 5-star topic. Pneumoconiosis is a general term for fibrotic lung diseases that start with inhalation of inorganic dust particles, like coal dust or asbestos or silica, lots of industrial things. And as the macrophages come in and try to clear out the dust particles, they release inflammatory mediators that can eventually lead to chronic fibrosis of the lung. Now, one type of inorganic dust that you might be exposed to is coal dust, especially if you work in a coal mine. So this is called coal workers' pneumoconiosis, or sometimes it's informally called black lung. And there are several different degrees of severity. The mildest form of the disease is called anthracosis. The word anthrax or anthrac is Greek for coal. So anthracosis is basically asymptomatic, and it occurs not just in coal workers, but also in people who just live in urban areas just from inhaling sooty, polluted air. Basically, you inhale carbon particles, and the alveolar macrophages engulf the carbon and accumulate in the connective tissue. The next level of disease is called simple coal workers' pneumoconiosis, and this is characterized by small, rounded, fibrotic lung nodules, mainly in the upper lobes of the lungs. And then after years and years, this can progress to complicated coal workers' pneumoconiosis, which is characterized by progressive massive fibrosis. Now, radiologically, coal workers' pneumoconiosis looks very similar to silicosis, which is another type of pneumoconiosis that minors can get. Silicosis is due to inhalation of silica dust, silicon dioxide. So coal miners are at risk of exposure to coal dust and silicon dioxide, and also radon, which is a risk factor for lung cancer. Silicosis is even more common than coal workers' pneumoconiosis because in addition to mining, you can be exposed to silica dust through sandblasting, construction, demolition, cement and concrete production, masonry and stone cutting, working in a foundry where they cast metal parts, fracking. Now, don't memorize this list. Just be aware that lots of occupations are associated with silicosis. So if you see sandblasting as an occupation on your test question, the first thing I want you to think about is silicosis. Now, in silicosis, just like the other pneumoconioses, the macrophages take up the silica and they cause inflammation. So these patients get innumerable tiny nodules, especially in the upper lobes, and these nodules can become calcified. You may also see eggshell calcifications in the hilar lymph nodes. And eventually, the inflammation can result in progressive massive fibrosis. Now, the silica crystals can also prevent the pulmonary macrophages from being able to kill mycobacteria. So silicosis can increase the susceptibility to contracting TB. So you can remember the diagnostic term silicotuberculosis. That may help you remember that association. And patients with silicosis have twice the risk of developing lung cancer. Asbestos is another substance that can be easily inhaled and then result in pneumoconiosis. Asbestos exposure is associated with shipbuilding, roofing, pipe fitting, and plumbing. And historically, asbestosis was also frequently seen in the spouse of people working in those industries because they were doing the laundry of somebody who was in that occupation, and those asbestos fibers had ended up on the worker's clothes. Once you inhale the asbestos fibers, they end up out in the peripheral parts of the lung, out near the pleura, and especially in the lung bases, which is different from the other pneumoconioses. And the asbestos fibers are directly toxic to lung parenchymal cells. And then they also get phagocytosed by those macrophages that release inflammatory mediators and free radicals, which do damage. The asbestos fibers become coated with an iron-containing proteinaceous material, and they're called ferruginous bodies, which look like dumbbells. Well, not much like dumbbells, but that's the classic description, so know that buzzword, dumbbells. These ferruginous bodies, or asbestos bodies, are seen with Prussian blue stain, and they kind of have a golden brown color and little beads on the end. Inhaled asbestos can cause localized plaques on the pleura, especially along the pleura that lines the diaphragm. It can be associated with recurrent pleural effusions, and of course interstitial fibrosis of the lung parenchyma, like the other pneumoconioses we've discussed. Aside from the pneumoconiosis, asbestos is also associated with an increased risk of several types of cancer, including laryngeal cancer, malignant mesothelioma, and lung cancer, both squamous cell and adenocarcinoma. But a couple of points about this. First of all, malignant mesothelioma is not a type of lung cancer. It's a pleural malignancy. It's a malignancy of the pleura. So it's located in the chest, but it's not lung cancer. And if they give you a patient with malignant mesothelioma, the most common cause is asbestos exposure. But, and this is a big but, bronchogenic carcinoma, that is lung cancer, is much more common than mesothelioma in patients who are exposed to asbestos. So if they give you a patient with mesothelioma, think asbestos exposure. But if they give you a patient with asbestos exposure and they ask what cancer is most likely in that patient, it's bronchogenic lung cancer. And finally, if you smoke on top of being exposed to asbestos, your lung cancer risk goes through the roof. Asbestos by itself increases your lung cancer risk by about 6-fold. Smoking by itself increases your lung cancer risk by about 11-fold. But smoking plus asbestos increases your lung cancer risk by about 60-fold. The last pneumoconiosis we're going to discuss is berylliosis. Berylliosis may be found in somebody who works on high-tech electronics, such as what might be found in aerospace manufacturing. Now, berylliosis causes non-caseating granulomas, similar to what we're going to see in sarcoidosis, and it also increases the risk of lung cancer. Next, let's discuss sarcoidosis. Sarcoid is at least a 4-star topic for your exam. Sarcoidosis is a disorder of non-caseating granulomas that affect a variety of tissues and organ systems, especially the lungs, but also the skin, the eyes, the joints, and so on. It's an idiopathic disorder, so we don't really know what causes it, but it does seem to be mediated by the immune system, which makes sense since macrophages and granulomas are involved. Now, sarcoid is 3 or 4 times more common in blacks than it is in whites, and it tends to be more common in women than in men, especially young women in their 30s and 40s. But it also clusters in families, and it clusters in certain geographic locations. It's just not very well understood. Now, in your study guide, we have a mnemonic for some of the more memorable, more testable features associated with sarcoidosis. The mnemonic is that sarcoidosis is a grueling disease. So the A is for an increase in the levels of serum angiotensin converting enzyme. That's not particularly useful clinically because it's not a sensitive or specific test, but it is testable for your exam. The G is for gamma globulinemia. 50 to 80% of these patients have high gamma globulin levels. R is for rheumatoid factor. So in addition to the high gamma globulin levels, many of these patients will have a positive rheumatoid factor. U is for uveitis and other ocular manifestations. Lots of different eye things, but the most common one is uveitis, or inflammation of the vascular layer of the eye, the uvea. The E is for erythema nodosum, which are tender erythematous nodules on the anterior surface of the legs, along the tibias, due to subcutaneous fat inflammation. Now, these are seen in other disorders as well, but they can certainly be associated with sarcoid. The L is for lymphadenopathy, especially bilateral hilar lymphadenopathy. That's a big clue to the presence of pulmonary sarcoid. I is for idiopathic. Then the N and G are for non-caseating granulomas. And finally, the D in disease is for increased vitamin D production by those activated macrophages in the granulomas. And that might cause some hypercalcemia, or more commonly, hypercalciuria, high calcium in the urine. Now, the body's going to fight to keep serum calcium levels normal, even if that means dumping more calcium into the urine. In general, the treatment for sarcoidosis is glucocorticoids, but there are other options depending on disease severity. But for your purposes, think steroids. The rest of these interstitial lung diseases are lower yield, so we're going to go through them fairly quickly. As the name implies, idiopathic pulmonary fibrosis is fibrosis in the lung that doesn't have a known cause. The other name for idiopathic pulmonary fibrosis is cryptogenic fibrosing alveolitis. So this disease appears to occur in individuals with a genetic predisposition to ineffective repair of alveolar epithelial cells after those cells have been injured by some environmental exposure like smoking. So there are 2 genetic mutations I want you to be familiar with. The first is a telomerase gene defect, and the second is a defect in mucin MUC5B. Now, this is a disease that affects older patients, and the median survival after diagnosis is just 3 years. On CT, the classic radiological description is called honeycomb lung. So there's fibrosis and some consolidation of the lung parenchyma with these cystic spaces that make it resemble a honeycomb. So be sure you can recognize what this looks like on your CT scan for step 1. But overall, the lung tissue looks very heterogeneous. There are some areas of honeycombing and other areas of interstitial inflammation and some areas of relatively normal lung. And altogether, this heterogeneous change is called usual interstitial pneumonia. There's another disease known as pulmonary Langerhans cell histiocytosis, which has focal collections of Langerhans cells, often accompanied by eosinophils. So it can also be called eosinophilic granuloma. And in those Langerhans cells, on electron microscopy, you may see these tennis racket-shaped cytoplasmic organelles, which are called Burbeck granules. Now, 95% of patients with this Langerhans cell histiocytosis are young adult smokers, and they get better if they just quit smoking. Next is Goodpasture syndrome, which is associated with anti-basement membrane antibodies. And you should also remember that Goodpasture syndrome can affect both the lung and the kidneys. It causes a form of glomerulonephritis. So in a patient with both lung disease plus glomerulonephritis, think about either Goodpasture syndrome or granulomatosis with polyangiitis. Now, granulomatosis with polyangiitis was previously known as Wegener's granulomatosis, so maybe you're familiar with that name. The classic triad for granulomatosis with polyangiitis is necrotizing granulomas of the lung and upper airway, necrotizing or granulomatous vasculitis, which is most prominent in the lungs and upper airways, and focal necrotizing glomerulonephritis. This is a 4-star disease for your exam, so we're going to cover it in a little more detail in the cardiovascular video on vasculitis. And finally, let's talk about hypersensitivity pneumonitis. So this is where a patient's exposed to various organic dusts, leading to hypersensitivity reactions and inflammation of the alveoli, which can lead to either acute or chronic lung disease. Now, there are nearly 40 different causes of hypersensitivity pneumonitis, with a lot of really specific names, like farmer's lung from inhaling moldy hay, or pigeon breeder's lung, or bird fancier's disease from inhaling proteins from birds, either from the feathers or from the serum or bird droppings. And for the purposes of your test, I don't think you really need to get into cheese washer's lung, or fish meal worker's lung, or mushroom worker's lung. The patient's history is basically going to clue you into the diagnosis of hypersensitivity pneumonitis. Restrictive lung disease can also be caused by medications, such as bleomycin, which causes pneumonitis with infiltrates, especially in patients over 70. Busulfan can cause acute lung injury, chronic interstitial fibrosis, or alveolar hemorrhage. Amiodarone is an antiarrhythmic drug that can cause significant pulmonary fibrosis in about 1% of patients. Remember, when you put somebody on amiodarone, you're going to monitor TFTs, LFTs, and PFTs, thyroid function, liver function, and pulmonary function. And then rarely, methotrexate can cause a hypersensitivity-like lung reaction, which is called methotrexate lung. And radiation therapy for lung cancer can lead to radiation pneumonitis, which causes a restrictive pattern on the PFTs. So now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go over the answers together. First question. A preterm neonate has difficulty breathing. An X-ray reveals diffuse airspace and interstitial opacities with air bronchograms. So another way to describe this is ground glass appearance. So what's the diagnosis and what could have prevented this condition? So the diagnosis is neonatal respiratory distress syndrome, and it could have been prevented with maternal steroids such as dexamethasone, ideally 48 hours prior to delivery, but even 24 hours of steroids is better than nothing. Next, what are the common causes of ARDS? So the causes include shock, infection, toxic gas inhalation, aspiration, high oxygen concentrations, pancreatitis, heroin overdose, sepsis, trauma, uremia, and amniotic fluid embolism. Last question. A lung biopsy from a plumber shows elongated fibers embedded in the tissue. These fibers appear to have clubbed ends. So what's the most likely diagnosis? This is most likely asbestosis. The structure we're describing is the dumbbell-shaped ferruginous body. Then the second question asks, what type of cancer is this patient most at risk of acquiring? Well, we talked about an increased risk for bronchogenic lung cancer, the classic malignant mesothelioma, and laryngeal cancer. But of these, the risk of lung cancer is the greatest, so that's the best answer. Now let's go through the rapid-fire facts. Bilateral hilar adenopathy and uveitis should make you think about sarcoidosis. Anti-glomerular basement membrane antibodies are seen in Goodpasture syndrome. Honeycomb lung on CT is seen with idiopathic pulmonary fibrosis. Tennis racket-shaped cytoplasmic organelles are the Burbeck granules of Langerhans cell histiocytosis. And iron-containing nodules in the alveolar septum are those ferruginous bodies, which suggest asbestosis. 297. 298. That's it for now. I'll see you next time. 300. All right. 1, 2, 3. Let's go over the warm-up. First question, which neurodegenerative disease is associated with each of the following statements? So dementia, often associated with frequent falls and or syncope, should make you think about dementia with Lewy bodies. Atrophy of the caudate nucleus resulting in chorea is Huntington disease. Depigmentation of the substantia nigra is Parkinson's disease. Both upper and lower motor neuron signs, so you're going to see spasticity plus weakness. That should make you think about ALS or Lou Gehrig's disease. Dementia plus visual hallucinations is dementia with Lewy bodies again. And then dementia plus personality changes and or aphasia is frontotemporal dementia or Pick disease. And the last question, which CD surface marker fits each of the following statements? So found on all natural killer cells and bind to the constant region of IgG, that's CD16. Inhibits complement C9 binding is CD55 and CD59. And then the endotoxin receptor found on macrophages is CD14. Now let's move on to the lecture.
Hello everyone and welcome to our video on lung cancer. Let's get going. So lung cancer is the leading cause of cancer death for both men and women in the United States with a 5-year survival rate of only about 16%. But it's not the most common cancer. You might get a question on this. In men, the most common cancer is going to be prostate cancer, and in women, the most common is going to be breast cancer. Now, we're not counting skin cancers, which are far more frequent than any of these. So what type of symptoms will a patient have with lung cancer? Well, the symptoms can be pretty mild at first, and eventually they can progress to things like a persistent cough, hemoptysis, chest pain. Other symptoms might include weight loss, night sweats, pneumonia, pleural effusions, airway obstruction, possibly one of the paraneoplastic syndromes, and we'll discuss that in a little bit as well. Now, identifying the type of lung cancer is probably a 4-star topic. You will most likely have a question on lung cancer in some form. Lung cancer is classified according to histological type. Now, the two big categories are small cell lung cancer and non-small cell lung cancer. Non-small cell lung cancer includes adenocarcinoma, squamous cell carcinoma, and large cell lung cancer. And then small cell lung cancer is kind of by itself, but it can also be referred to as oat cell cancer. So again, the 4 main histological subtypes of lung cancer: adenocarcinoma, squamous cell carcinoma, large cell, and then small cell carcinoma. So next, let's move on to adenocarcinoma. So adenocarcinoma is the most common type of lung cancer, accounting for about 38% of lung cancers. Now, it's found in the peripheral areas of the lung, important to remember that. Often these cancers are found on pre-existing parenchymal scars. Now, adenocarcinoma is usually related to smoking, but also know that adenocarcinoma is the most common lung cancer found in non-smokers and in females. Now, mutations associated with adenocarcinoma include MET, ALK, RET, KRAS, EGFR, and ROS. Now, we got a great mnemonic from a student recently that noticed that this order actually spells out marker. So remember, marker is going to stand for MET, ALK, RET, KRAS, EGFR, and ROS. Moving on to squamous cell carcinoma. Squamous cell carcinoma, the second most common type of lung cancer. It's about 20% of lung cancers. Squamous cell carcinomas are found more centrally in the lung. So we just talked about it being more on the peripheral in our adeno, and squamous cells can be more in the center. So this will often present as a hilar mass from the bronchus, though it may also appear as maybe kind of a cavitated lesion on an X-ray or a CT scan. It's also very strongly associated with smoking. Now, on histology, there might be something called keratin pearls, which is a very classic finding in many squamous cell cancers. Now, squamous cell cancers are also known to secrete certain hormones. So we're talking about paraneoplastic syndrome. The most common hormone secreted is the PTH-related protein. So remember, PTH stands for parathyroid hormone. So what would you expect to see with a bunch of PTH-related hormone coursing through the body? Well, you're going to see hypercalcemia. So the first sign of a squamous cell carcinoma might just be an elevated calcium level or maybe signs of hypercalcemia. Let's move on to large cell carcinoma. Large cell carcinoma also found in the peripheral sides of the lung. It is strongly associated with smoking again. And these cells are anaplastic and undifferentiated. And giant cells are seen with kind of various kind of pleomorphisms. And this cancer has a very poor prognosis and responds pretty poorly to chemotherapy as well. And then finally we have our small cell lung cancer. So this takes care again of our non-small cell that we were talking about before, now the small cell. The cancer is called small cell because the nucleus to cytoplasmic ratio is very high. And small cell carcinoma, like squamous cell carcinoma, is associated with smoking pretty strongly. Additionally, it arises centrally just like squamous cell carcinoma. It also has the capacity to secrete hormones. So you can actually use, this is a good mnemonic, the sound S to remember some of the characteristics of squamous cell carcinoma and small cell. So squamous, small, they're both central, they're both associated with smoking, and they're also secreting a lot of stuff. So what hormones might our small cell lung cancer secrete? Well, there's a couple of things. Remember, we saw a PTH-related hormone with squamous cells. Small cell lung cancer might generate ACTH, or it might also produce ADH, resulting in Cushing syndrome with that ACTH production, or SIADH with ADH production. Small cell might also generate antibodies against presynaptic calcium channels. The result of these antibodies is going to be what's called Lambert-Eaton syndrome, and it's characterized by muscle weakness. Now, you might recall that Lambert-Eaton syndrome is weakness that actually improves with use. So there are three perineoplastic syndromes you got to remember with small cell lung cancer: that Cushing syndrome, that SIADH, and then Lambert-Eaton syndrome. Now, small cell is a particularly bad lung cancer. They're all pretty bad, actually. It is undifferentiated. It's very aggressive, which leads again to an even poorer prognosis than average. Now, one last thing to know about small cell lung cancer is that it is associated with aberrations in the TP53 and the RB, as well as amplification of the MYC oncogenes. Let's move on to carcinoid tumors. So carcinoid tumors of the lung are also worth mentioning here, though they only represent about 1 to 5% of all lung tumors. Now, carcinoid tumors are low-grade malignant epithelial tumors that may sometimes secrete serotonin. That's going to result in carcinoid syndrome, which is characterized by things like flushing, diarrhea, wheezing, and salivation. Now, you might remember there's a mnemonic for this one. It's called BFDR. B is for bronchospasm, so that's the wheezing. F is for flushing. D is for diarrhea. And then the R is for right-sided heart lesions, so right-sided valvular lesions, right-sided heart murmur. Now, the two most common locations for carcinoid tumors are in the lungs and the GI tract. Now, it's the most common tumor of the appendix as well. Now, about 75 to 80% of patients with carcinoid syndrome, so all that flushing, will have small bowel carcinoids. But most carcinoid tumors do not secrete serotonin and do not metastasize, and it makes them much easier to resect. Let's move on to Pancoast tumor. So a Pancoast tumor is actually any type of histological lung cancer that is found in the apex of the lung. Most Pancoast tumors, though, are the non-small cell lung cancers. So here we have an image, and you can actually see an example of this in the upper portion of the lung. And because of its location, it can affect the cervical sympathetic plexus, and it can cause the famous Horner syndrome. So do you remember the characteristics of Horner syndrome? Remember, it was ptosis, so that's drooping of the eyelid, and usually that's just going to be unilateral. You have meiosis, so that's going to be constriction of the pupil, and then you're going to have anhidrosis, so that's going to be decreased sweating of the affected side. Now, the tumor could also compress the recurrent laryngeal nerve, which will result in hoarseness. Next, let's move on to mesothelioma. So mesothelioma is located in the pleura, or the outer lining of the lungs. Now, it's associated with asbestos exposure. There is actually no association between mesothelioma and smoking. Now, the prognosis is generally pretty bad for mesothelioma, with 50% of patients dying within about 12 months of diagnosis. Now, this can be a little bit tricky with test questions. So if you're given a patient with malignant mesothelioma, the most common cause is going to be asbestos exposure. But if you're given a patient with asbestos exposure, you need to know that they are actually still much more likely to get a bronchogenic carcinoma, more so than a mesothelioma. So mesothelioma is not the most common lung cancer in patients with asbestos exposure. It's actually still just bronchogenic carcinoma. Okay, guys, so those are the major lung cancer types. Let's hit the high-yield stuff again in the Lewis notes. All right, everyone, welcome to another Lewis Notes. We got a lot of info to go through on our lung cancers. Let's just go ahead and get going here. So we're going to do location and characteristics. And first we're going to start with adenocarcinoma. And remember, its location is more peripheral, so put a P right there. You can make your own chart here. Some of the big things. Remember that adeno is the most common. So first, most common. But the other thing to remember that you might see on tests is that it's also most common in non-smokers. So think of non-smokers as getting this type of cancer more often. And then there's a bunch of genetic type things you have to remember. And this can be pretty rough. So we have KRAS, we have this EGFR, we have ALK, ALK, we have ROS, we have MET, and then we have RET. So remember those. Those are probably the trickiest part of actually all of this today is kind of remembering all the gene associations. Let's move on to squamous. Remember that squamous is central, so you can put a big C right there. This is the second most common, so remember that's the second. It's also very closely associated with smoking. So remember, smoking is a big one for this one. Remember on, if you're looking under the microscope, you might see keratin pearls. So keratin pearls, another thing to write down here. And then the other is, remember, we have our paraneoplastic syndrome stuff. So remember, it's our PTH related proteins. And what's that going to lead to? Remember, that's going to lead to some elevated calcium as being a potential first thing to see. Moving on to large cell, we're back to a peripheral cancer. There's not a whole lot with large cell. It's also associated with smoking. Not a lot of high yield stuff with this one. Remember, this one has a poor prognosis too. It's undifferentiated. So poor prognosis for large cell, but not a lot of buzzwords with large cell. Now, small cell, we got a ton of stuff to talk about. So remember, it's another central. It's also smoking is its big one. Remember all those S sounds for squamous and small. It also goes for smoking, central, and then secreting. So what is it going to secrete? Remember, it's going to secrete ACTH. It's also going to secrete ADH. That's another big one. And remember, it's going to do those calcium channel antibodies. So we have antibodies going after those things as well. And that's going to lead to our Lambert-Eaton syndrome. So remember that. You can get Cushing syndrome, that SAIDH, and then the antibodies are going to lead to that Lambert-Eaton syndrome. And remember, with Lambert-Eaton, you get that muscle weakness, but it gets better with use. And this one does have some gene stuff too. So remember TP53, remember RB, and then the MYC, the MYC gene, the oncogene is the ones you got to remember on that one. All right, so then we have maybe our smaller in importance tumors to some extent. Remember our Pancoast tumor, those are going to be in those apexes. So remember the apex of the lung. And the big thing you got to remember with Pancoast is that Horner syndrome. So remember Horner in regards to Pancoast. Mesothelioma, remember that's going to be in the pleura. So there's a lot of anatomy. It's as important with all these types of tumors. And remember the big one here is going to be asbestos exposure. And then for carcinoid, this is going to be in the lung, but it's also in the GI tract. And remember, depending on its location, you can get the carcinoid syndrome. So carcinoid syndrome, it has to be outside of the GI tract in order for it to happen, for that serotonin to affect. So if it's just in the GI tract, you're not going to see the carcinoid syndrome. If it's in the lung or if it's metastasized out of that GI tract, then you're going to see that carcinoid syndrome. You're going to see that bronchospasm and that flushing, all those serotonin type things. All right, so those are what I think are probably the biggest high yield things. And if you can remember that stuff, then I think you'll be okay for your test. All right, so we're back. So again, those were the major pulmonary cancers that we're going to cover, but there are just a few more important points to mention. Another important fact worth knowing is where lung cancer tends to metastasize to. The most common sites of metastasis are the brain, bone, liver, and adrenal glands. Also, the lungs are an organ receiving metastasis pretty often as well. And these mets can arise from other types of cancers like breast cancer, colon cancer, prostate cancer, or even bladder cancer. Another important point is that in addition to smoking, other risk factors for lung cancer exist. The one you need to probably remember is radon exposure. Radon is a heavy gas, so it can settle down into the basements or deep down in coal mines, among other places. If you're exposed to radon, then you're going to have a higher incidence of lung cancer. And finally, I want to recap some of the complications that can arise from lung cancer again. We mentioned initial symptoms including that cough and hemoptysis, chest pain, as well as weight loss, night sweats, pneumonia, pleural effusions, airway obstruction, possibly one of the paraneoplastic syndromes. And again, those paraneoplastic syndromes we discussed were hypercalcemia from elevated PTHrP in squamous cell cancer. And remember that SIDH, Cushing syndrome, and Lambert-Eaton associated with the small cell lung cancer. Now, additionally, we discussed that hoarseness can occur with recurrent laryngeal nerve involvement. There can be Horner syndrome associated with that Pancoast tumor. There can also be that dysphagia, maybe even esophageal invasion from lung cancer. And one last complication to mention is the superior vena cava syndrome, where a tumor is obstructing the FVC. It's going to impair blood draining from the head, so that can be a big tip-off that there's lung cancer as well. All right, so that's all you need to know about lung neoplasms for a test. It's time for that end of session quiz. Try to answer those on your own, then we'll go through them together. All right, first question. What is the classic histological appearance of squamous cell carcinoma of the lung? So on histology, there might be what's called those keratin pearls, which is a very classic finding in many squamous cell cancers. Next question, what complications can arise from lung cancer? This is a real long list here, but important to remember because you might get these presentations you need to think of lung cancer as being the cause. So remember that superior vena cava syndrome, also Horner syndrome, and then there's also those paraneoplastic syndromes. Remember, it's squamous cell lung cancer. You can get that PTH-related peptide causing that hypercalcemia. Remember that small cell cancer can make ACTH, that can cause Cushing syndrome. Small cell can still also make ADH, causing SIADH, and you might even just see that as hyponatremia. Small cell can also elaborate autoantibodies against calcium channels. So what did that cause? Remember, it was the Lambert-Eaton syndrome, so you get a lot of weakness. Additionally, you can have invasion into the recurrent laryngeal nerve. That can cause a lot of hoarseness. You can get pleural effusions. You can get invasion into the esophagus, so you can have an esophageal invasion and get a lot of dysphagia. And you can even have a laryngeal invasion as well. So all that stuff can all come from lung cancer. Next, what are the 4 most common locations of lung cancer mets? So you're going to go to the brain, the bone, the liver, and the adrenal glands. All right, that brings us to the end of the primary stuff, but we do have a couple rapid fire facts, and this will again institute our memory on this. So first, we have lung cancer associated with SIADH. Remember, that was small cell lung cancer. Tumor associated with Horner syndrome, so that's going to be Pancoast tumor. Lung cancer associated with hypercalcemia. So remember, that's going to be our squamous cell. Remember, that had that PTH-related peptide. Next, we have lung cancer associated with Cushing syndrome. Again, it's small cell producing that ACTH. Lung cancer associated with weakness. Again, small cell. Remember, that's called Lambert-Eaton syndrome. Substances associated with lung cancer. We talked about tobacco use, so smoking is a big one. Radon, silica, asbestos, again, associated with cancer as well. All right, guys, that brings us to the end of our lecture overall. I hope you learned something. I'll see you next time.
Let's go over the warm-up review. First question, what nerve is most at risk of damage with each of the following injuries? Fracture of the medial epicondyle is going to be the ulnar nerve. Anterior shoulder dislocation is the axillary nerve. An injury to the carpal tunnel is the median nerve. Next, which lysosomal storage disease matches each of the following statements? So the diseases characterized by the accumulation of dermatan sulfate are Hurler disease, Hunter syndrome, and Shy syndrome. And then deficiency in hexosaminidase is a feature of Tay-Sachs disease. And last question, what's the difference between direct bilirubin and indirect bilirubin? Well, direct bilirubin is conjugated to glucuronic acid to make it more soluble, and then indirect bilirubin is unconjugated. So indirect is unconjugated. Pretty easy to remember. Now let's get started with the lecture.
McGinnis, a man who is bland. His job is to teach, but his jokes overreach. But as soon as he speaks, we all fall asleep. It's sad, I know, and the students all weep. Please, McGinnis, you're in too deep. Lewis is strong with more up his sleeve. And now it's time to take the test. Your intros are sad, you must confess. And though you're dressed for success with colored shirts and hair caressed, my beard and I are not impressed. Welcome to the battle, this won't take long. With beats so sick and rhymes so strong, McGinnis is lagging with harmonica songs. I'm wrecking your intros like mighty King Kong. The students all wait with barely a murmur, worried for McGinnis whose hands start to tremor. You see, I'm the chief and you're the learner. In Thunderdome, I'm Mad Max, you're Tina Turner. My intros are gold, your comedy stinks. I'm Darth Vader, you're Jar Jar Binks. My rhymes are sick, your diss is baloney. I'm the Black Stallion, you're My Little Pony. Hello everyone and welcome to our step 1 video on lung infections. Let's get going. So we're going to talk about some lung infections and then we're going to end up on sleep apnea at the end. So first we're going to talk about pneumonia. So pneumonia is an infection of the lung. Now specifically we see inflammation in the alveoli. So it is still a major cause of death in developing countries. Now it can be caused by bacteria, by viruses, by fungi, all sorts of stuff. Now pneumonia can also be caused by aspiration from the oral pharynx. Therefore, people who suffer from alcoholism, nasogastric tubes, intubation, obtunded states will certainly increase the risk of contracting that type of aspiration pneumonia. Now there are several ways to categorize pneumonia. One method is to divide pneumonia into community-acquired pneumonia and hospital-acquired pneumonia. So the community-acquired pneumonia consists mostly of gram-positive organisms. Now the hospitalized acquired pneumonia patients are still prone to those same bacteria, but you also tend to see more gram-negative rods as well. And then another common method to group pneumonia is by clinical manifestations. Two big ones are what we refer to as typical and atypical pneumonia. Now these two types will usually correspond with two different groups of causative bacteria as well. So the typical pneumonia will present with fever, cough, malaise, purulent sputum, chest pain, shortness of breath. So it's really just the symptoms we most commonly attribute to pneumonia in general. On chest x-ray, you're going to see a lobar infiltrate that will white out a significant part of a lung. And these patients are generally pretty ill. Now, the most common bacteria we see in this picture of typical pneumonia is Streptococcus pneumoniae. But other bacteria are going to include things like Staph aureus, H. influenza, and group B strep. Now let's talk about atypical pneumonia. Atypical pneumonia will present with less severe symptoms. Patients generally have a non-productive cough. They have some headache, they have some fatigue, but overall they can still function in everyday activity. Some people are still going to work. And this is often even referred to as walking pneumonia because people are walking around while they have it. Now the x-ray will show something different. Remember we talked about a lobar, a big whiteout of the other one, usually on one side. This x-ray is going to show kind of a diffuse, patchy looking infiltrate. The chest x-ray will often look quite a bit worse than what the patient is looking like. Now the bacteria that tend to cause this type of pneumonia include things like Mycoplasma pneumoniae, Legionella pneumophila, and then Chlamydophila pneumoniae. Now be careful about this classification. There are some references that will lump a lot more bacteria into the atypical category. They tend to take really anything other than strep pneumo, Staph aureus, and H flu and lump them all into an atypical category. I don't necessarily agree with this. I would divide them on a clinical presentation, those chest x-ray findings. All right, so now instead of spending a ton of time on every type of bacteria that causes pneumonia, I'm going to hit you with the biggest high-yield facts that you're going to more than likely see on your test. Now, most of these bacteria and fungi are going to be covered in more detail in our micro section anyway. So this is kind of more of a review / preview of pathogens that cause pneumonia. So go ahead and look in your study guide. We're going to follow along here. If you know all these, then I think you're going to do pretty well on your test. These will be the big buzzwords that you need to know. So first one here, common cause of pneumonia in immunocompromised patients. You want to think first here about pneumocystis jirovecii. So this causes our PCP pneumonia. Next, we have most common cause of atypical walking pneumonia. We talked about before. What was the most common one of those? Well, it's Mycoplasma pneumoniae. Next, we have common causative agent for pneumonia in alcoholics. So we got to think about aspiration. Now, it's not necessarily the most common, but the one I want you to remember that you'll see on your test is going to be Klebsiella pneumoniae. Next, can cause interstitial pneumonia in bird handlers. So this one's a really weird and unique one. This is Chlamydophila psittaci. Next, we have often the cause of pneumonia in a patient with a history of exposure to bat and bat droppings. That's going to be histoplasma. Next, we have often the cause of pneumonia in a patient who has recently visited Southern California, New Mexico, West Texas. That's going to be coccidioides. Next, we have pneumonia associated with current jelly sputum. That's going to be Klebsiella again. Q fever. That's going to be caused by Coxiella burnetii. Associated with pneumonia acquired from air conditioners, that's going to be Legionella pneumophila. Most common cause of pneumonia in children 1 year old or younger, that's going to be RSV, respiratory syncytial virus. Next, we have in neonates. So this is going to be one of two things. You got to think about group B strep or E. coli, both very common causes of pneumonia in this age group. Next, we have most common cause of pneumonia in children and young adults. That's going to be Mycoplasma pneumonia again. Next, we have most common cause of viral pneumonia. That's going to be RSV. Causes wool sorters disease. That's going to be Bacillus anthracis. Common pneumonia in ventilator patients and those with cystic fibrosis, that's going to be Pseudomonas aeruginosa or also MRSA, methicillin-resistant Staph aureus. So both of these are really neck and neck for most common cause of pneumonia in ventilator patients. And then we have Pontiac fever. That's going to be caused by Legionella pneumophila. So, okay, if you really don't know this stuff, try to quiz yourself a few times on these really high yield things. Get them in your noggin. Again, we're going to have a lot more detail on many of these in other videos, but this is just a good preview for you. All right, so now let's move on to lung abscess. So this is necrosis of the pulmonary parenchyma. Now generally there is a collection of pus in the lung. Now most lung abscesses are a complication of aspiration pneumonia and are caused by anaerobes that are normally present in the gingival crevices. So we're actually being infected with our own bacteria. Therefore, patients with an altered level of consciousness are at the most high risk here. Alcoholics, drug abusers, also general anesthesia, intubation, that sort of thing. And it can result from bronchial obstruction as well. Now, the most common bacteria include Peptostreptococcus, Prevotella, Bacteroides, and Fusobacterium. But other outside bacteria can cause this as well, including Staph aureus, Klebsiella pneumonia again, and also gram-negative bacteria as well. So many bacteria can cause lung abscesses. You're probably not going to get a question that says, well, what's the most common bacteria in an abscess? It's just too many to count there. Now on imaging, you might see air fluid levels and cavitations. Imagine just a great big ball of pus in your lung. It's really not very pretty. So what's going to be the first line treatment for an abscess? Well, of course, you want to identify the specific bacteria, but empirically, since we're dealing with anaerobes, you're probably going to start with something that will treat anaerobes, something like clindamycin. Moving on to pleural effusions. A pleural effusion is fluid that's going to accumulate between the two pleural layers. Now this can impair breathing because it can limit the expansion of the lungs overall. Now on x-ray, the air space will look like it's obliterated. If the pleural effusion is very large, you won't see much in there at all, just kind of a big whiteout. The fluid, depending on its viscosity, will also tend to layer according to gravity. So when the patient is upright, then the fluid layer is going to go to the base of the lung. Let's look over in the study again. We group these into transudative and exudative effusions. A transudate has very low protein content and a high electrolyte content. Diseases that lead to a transudative pleural effusion include things like CHF, cirrhosis, nephrotic syndrome, even fluid overload states. So the reason behind the effusion is due to either an increase in hydrostatic pressure, so things like CHF and fluid overload, there's just too much fluid there, or a decrease in oncotic pressure. So that's going to be the examples of cirrhosis and nephrotic syndrome. Now in these disease states, it's difficult to keep fluid in that vasculature and therefore it's just leaking into the pleural space. Now one good memory tool is transudate is more transparent. So transudates have less protein, they're more watery than exudates, so they're more transparent. You can kind of see through that fluid. So now let's move on to what causes an exudate. Things like cancer, pneumonia, infections, TB, uremia, and connective tissue diseases, they can all cause an exudate. Now the fluid has a high protein level to it. The exudates result primarily from pleural and lung inflammation, which can then lead to an increase in membrane permeability. And these pleural effusions are generally going to be drained because of the risk of worsening infection. You can also have a lymphatic pleural effusion. When do you get a lymphatic pleural effusion? Well, your thoracic duct actually goes through that region close to your lung. Your thoracic duct is going to carry lymphatic fluid back to your circulation. And so if you rupture or occlude your thoracic duct, think of like maybe a bad cancer, all that lymphatic fluid can potentially go into the pleural space and cause a lymphatic pleural effusion. Now, lymphatic fluid is very milky looking because it's very high in triglycerides. There's a specific name to that type of pleural effusion that's full of lymphatic fluid. It's called a chylothorax. So why is it called chylothorax? Well, we just said that lymphatic fluids are high in triglycerides, so that should make you think of chylomicrons. So remember from your diet, you absorb your triglycerides, they go into your lymphatic fluid as chylomicrons, they're digested into those chylomicron remnants, and then they go into the liver. So that's why it's called a chylothorax. All right, so we're moving on to sleep apnea. We have a little extra time here. We're going to switch gears, talk about something that actually has nothing to do with infections, and that's going to be sleep apnea. Sleep apnea occurs when a person stops breathing for an extended period repeatedly during sleep. Now, one type is called central sleep apnea. It's not as common, where there's actually no respiratory effort. So this is more common among premature infants, but can also occur in adults as well. Treatment for central sleep apnea will include things like CPAP. You might try BiPAP. There's another thing called ASV, which stands for adaptive servoventilation. It's a form of respiration where it's trying to synchronize those breaths with the patient's breathing as well. Supplemental oxygen is often indicated. You may also give them respiratory stimulants. Acetazolamide is used in this case. However, the results of all of these will greatly vary from patient to patient, and again, not very common. Now, obstructive sleep apnea, much more common of a scenario. We see this all the time. And this occurs when there is respiratory effort, but against airway obstruction. And this leads to abnormal respiratory patterns. Now, patients will continue to have apnea episodes where the patients will cease to breathe, sometimes on average between 20 and 40 seconds for a pretty long time. And so what's causing all this obstruction? Well, often it's the soft palate kind of falling back in place. Sometimes the tonsils can also be swollen. They can be obstructing the airway as well. You see that sometimes in children. Now, obstructive sleep apnea is associated with obesity, loud snoring, and a lot of daytime fatigue. Now, the typical patient will be kind of an obese male with a very short neck, but it can happen in females and other people as well. Now, the most common complaint is daytime fatigue, decrease in concentration as well. Patients with obstructive sleep apnea are 2 to 3 times more likely to get into a motor vehicle accident. Now, patients will have hypoxemia during sleep. Untreated obstructive sleep apnea can increase the risk for hypertension, for pulmonary hypertension, for stroke, and for coronary artery disease. So it's not just a sleepy problem. This leads to other major disease states. Now, diagnosis is with the polysomnography, which is also called a sleep study. If there are more than 5 obstructive apneas or respiratory effort-related arousals per hour of sleep, then you have that diagnosis of obstructive sleep apnea. So what is the first-line treatment for obstructive sleep apnea? Well, it's actually just weight loss, but pretty close on the heels of that is going to be CPAP. And CPAP stands for continuous positive airway pressure. So a CPAP machine just gives a constant pressure to help keep the airway open and intact. Now, surgery is also a potential option as well. Now, when there is significant tonsillar hypertrophy, you can take those tonsils out. So a tonsillectomy, often you're going to do an adenoidectomy as well at that same time, and that can help with a lot of these patients. And then in very bad scenarios, you can remove the soft palate and the uvula as well, and that's kind of last resort. Also, patients with sleep apnea should be cautious with sedatives because if you give them alcohol, benzodiazepines, or other sleep aids to help them sleep, you can actually make that sleep apnea quite a bit worse and make them even more hypoxemic. Now, rarely we need to use stimulants during the day to wake people up, things like modafinil, some of the other amphetamine-type drugs we'll use as well, just to wake people up because their sleep apnea is so bad. All right, that's it for the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. All right, first question. A 30-year-old comatose man on ventilatory support in the ICU develops an infection and dies. Autopsy reveals a pus-filled cavity in his right lung. What is the likely etiology? Well, this patient is on a vent, and in this case, aspiration pneumonia is going to be the most common cause of pneumonia here. So in that scenario, you had aspiration that resulted in that lung abscess. The most common bacteria there is going to be anaerobes, maybe some gram-negative stuff as well. Next, what infectious agent is the cause of pneumonia with the following characteristics? So some of our high-yield stuff again. So remember, most common cause of viral pneumonia was RSV. Current jelly sputum, remember that was Klebsiella pneumoniae. Most common cause of atypical walking pneumonia, that's going to be Mycoplasma pneumoniae. Gram-positive cocci in a neonate, think of Group B strep. And then partner to that, a gram-negative rod in a neonate, think of E. coli. Next, 50-year-old obese man complains of daytime fatigue and his wife complains that the patient snores very loudly. What is the best diagnostic test and what is the treatment? So remember that best diagnostic test is the polysomnography, that sleep study. Treatment's going to be mostly a lot of weight loss if you can get them to do it, but primarily you're going to get CPAP on these patients. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.